hearing on a number of bills. I don't think we're going to set any records today, but you never know. I will now turn it over to my esteemed co-chair, Senator Mary Doherty Abrams. Good morning.
Good morning, Representative Steinberg, and good morning, members of the committee. Always wonderful to see you all. I say we get started. We have 41 people signed up to speak today, and a lot of bills to cover. So let's have a great day. Thanks.
That sounds like a great way to start off. Senator Wong.
Thank you, Mr. Chair. Eager to get started again. It feels like deja vu. We've been doing this quite a bit, so looking forward to moving on.
Does seem rather deja vu-ish. Let's see. I do not yet see. Yes, Representative Pettit.
Thank you, Mr. Chairman. Just to reiterate the sidebar that I don't know if was live when you had it for the constituents out there. A number of folks have education, transportation, finance, a number of the meetings. So constituents will see people bouncing in and out of a variety of meetings because there's a lot of overlap today with hearings. Thank you.
Thank you for pointing that out, Representative. The only good news is, in some ways, it's actually easier to be in multiple places at once in the Zoom world than it is at the Capitol. So hopefully we'll all catch as much of the testimony as we possibly can today. Without further ado, let us move to the agenda. Our first up today is Commissioner Vicki Veltri of the Office of Health Strategy. Good morning, Commissioner. Assuming you're there. I see you. Commissioner Veltri.
She's having trouble hearing. I think she's trying to.
I can't hear.
She can't hear us. We can.
I can't hear.
So why don't you just go ahead?
I don't know what to do here.
Go.
Am I hearing anything?
Well, we may come back to you if you want to try to log back in again, Commissioner. Why don't you try to log back in again? We'll start off with Senator.
I can't hear. Can you hear me?
We can hear you.
Can you guys hear me?
We can hear you.
Okay. I cannot hear you at all. So I don't know what's going on my side of the equation here.
It's a great way not to have
but I will testify, and then I'm going to have to, I guess, rely on my compadres to help me out with questions. So good morning. I'm Vicki Veltri. I'm Executive Director of the Office of Health Strategy. I want to testify today in support of our bill, which is House Bill 6550. This bill improves community benefit programs administered by hospitals. In just a little background on community benefits under federal law, nonprofit hospitals, in order to substantiate their tax-exempt status, must disclose the amounts they spend on community benefits to the IRS on Schedule H. And community benefit programs are defined as programs that provide treatment and promote health and healing to individuals residing within a nonprofit hospital's geographic service area. The purpose is to meet the healthcare needs of underserved populations, provide services or programs that would likely be discontinued without the support of the nonprofit government entity, and address public health initiatives. The programs are meant to be tailored to the needs identified in each hospital's community health needs assessments, and then carried out through a comprehensive implementation strategy, also known as a community health improvement plan. OHS collects these 990s every year. However, several hospitals have told us that the Schedule H really limits their ability to provide sufficient detail about their spending. And the GAO, the General Accountability Office, agrees. In 2020, September 2020, the GAO put out a report suggesting that the IRS either needed to revamp the Schedule H or align with several states that are doing their own initiatives to improve community benefits reporting. So that's what this bill aims to do, is to do a better job for hospitals to outline the activities they are undertaking to improve community health spending. Under current law, OHA, the Office of the Healthcare Advocate, has jurisdiction over the community benefit reporting. This law or this bill would switch that to OHS. OHA is in support of this bill. We are currently taking on that duty actually through an administrative memo, but this bill would finalize that. The bill strengthens the integration of meaningful community participation from the hospital's geographic area in both the community health needs assessment and the community health improvement plan, so that community benefit investments are tied to each community's health and equities and distinct needs. It promotes greater collaboration between diverse local provider groups, including hospitals, which will lead to more innovative, impactful interventions to help address social determinants of health or root causes of illness, which will ultimately improve healthcare outcomes and drive down costs. We think we can work in collaboration with our hospital systems, our hospitals themselves, and our community partners to substantially improve community benefit reporting. I will also say this bill includes a spending threshold. 6 other states have community benefit spending thresholds. That said, we think if we can improve the community benefit reporting with meaningful participation from our partners, that may actually assist hospitals improving their reporting, and tying their reporting to needs in the community will help improve the investments overall. We have attached to our testimony a table that brings together the hospital reporting and shows the division of different activities under the community health, the community benefits rubric of spending. Over time, you'll see that some of the spending is in community benefit improvement, and community building activities is about 2% or 1% of the overall community spending. We think we can work together with our partners to improve that and to make sure people's needs in the community are satisfied. OHS has had an ongoing relationship with the hospitals in several initiatives on health enhancement communities, which is an upstream intervention initiative with collaboratives around the state to work together to improve the health of communities, and an anchor institution strategy. We think those two things working together will help improve the community benefit spending and make this kind of reporting more transparent, because at the end of the day, that's what this bill does, is improve transparency on community benefit spending, which 14 other states have also done, I might add. And we think it's really important for people to understand where community benefit dollars are going. So that's what this bill is really about. We think it has a chance to really do good work here in partnership with our hospitals and stakeholders around the state. With that, I would take questions, but I cannot hear a thing, so I'm not sure what to do here.
I'm going to make a suggestion.
I don't know whether I should
know that-
log off and come back in. Would that be okay?
That'd
And
be
Kelly
fine.
and Brent,
Yes,
Kelly
why don't you do
Cinco.
that? Yes.
From our offices here. And I'm going to let them start. I'm going to go off and try to come back on. I hope someone will let me back in.
Okay.
Let me see what I can do.
Kelly, perhaps we can start off with a question for you, if you don't mind.
Sure. Yes, and I'll try to answer the best of my ability, and we'll get through this together.
Hopefully the commission will be back really soon. Obviously, I think we're all agreed that the idea of transparency when it comes to community benefits is a good thing for Connecticut hospitals. But I imagine you've also heard some pushback from the hospitals that there is some redundancy in the reporting requirements, and there's some concern about this being a bit onerous compared to what they're currently doing. Have you had conversations with CHA and with some of the hospital systems in recent times?
Yes, we have been in touch with the Connecticut Hospital Association and have heard some of their concerns. We are very much willing to work with them. Part of our testimony today, we spoke about really the importance of the transparency. What is being submitted now is the 990 form, the Schedule H from the IRS, which is really supposed to substantiate their tax exemption and sort of lays out the different money amounts they use for the different community benefits. What we're asking for is just a little more transparency about, besides the number, what it's actually going to, because it isn't really clear from those tax documents right now. And we can also share with the committee a GAO report, which also talks about the IRS's ability to even glean information from that itself, from the federal government, and they're making recommendations that maybe it should be a little more specific. And one more point I'd like to make is that our statute for this reporting requirements was put into place before the Affordable Care Act, which had some changes about what needed to be added in. So we do think it's appropriate at this time to make some updates, and we are willing and ready to work with the Hospital Association to make sure they understand the requirements. We can do testing with them and just make sure we're all on the same page, because we obviously understand that they're under a lot of pressure and stress with COVID right now. And we obviously don't want to add administrative burden where we don't need to, but we just think that this is very important and can help them show as well and be transparent about what they're doing to their community.
So Kelly, I can actually hear now.
Oh,
And
great.
I am so sorry to
It's a
the committee.
miracle.
I apologize.
It
I
is
went
a
off and
miracle.
and Kelly's point about the ACA is really important. And I have a little history here because I was around when some of this happened. So the original legislation was put in place in 2003. It was updated in 2008 to give the reporting to the Office of the Healthcare Advocate. I remember because I was at the Office of the Healthcare Advocate when that happened. The ACA passed and this statute was never updated. And most states have updated it to reflect the community health needs assessments and the collection of data surrounding those needs assessments. So at a bare minimum, updating this legislation is a fair reflection of the Affordable Care Act. But we do think in that sense, there won't be an additional burden once we do meet and hammer out the exact reporting requirements. We do think that there's a way to partner on this, and it's important. It really is important for the health of the communities where the hospitals are. And they've taken that on because we've worked together with them on these community health initiatives. So I think they realize also the importance of sharing information.
Thank you for that. I'm guessing that Representative Pettit may have a follow-up on this, Representative?
A couple of follow-ups, Mr. Chairman, if you're all set. First of all, yeah, that was a number of the hospitals had reached out, were concerned about the additional information. And I'm wondering, and I'm clearly not an IRS expert, but I've looked at the 990s for a lot of the last 14, 15 years. I'm wondering if the information we want can be put in an appendix of the 990, because after looking at a lot of 990s for years on charitable organizations, some are very helpful in terms of what they give you, and some give you very sparse information. So perhaps we need to ask that the information we're looking for be appended. So I don't know if that's possible or not. So I guess that's more of a comment or a suggestion to the accountants of the world, if that's possible. Secondly, they'll tell me what to do, I'm sure. The Universal Healthcare Foundation has submitted testimony speaking to the need to submit information concerning race, ethnicity, et cetera. And I'm sure you heard a lot of the testimony on 6424 in that regard. And I just wondered what your comments were in terms of trying to make that a less contentious issue in terms of having people opt in, et cetera, or having to be voluntary, or because that issue will create a contentious area with some parts of the population. So I wonder what your thoughts are on that.
So two things. Thank you for the question. Let me go back to the first one first. As Kelly cited, there was a GAO, General Accountability Office of in the United States Congress, did a report on community benefit spending. And that was at the behest of Chuck Grassley, I believe, Senator Chuck Grassley and others who were concerned about the level of community benefit spending going on at hospitals around the United States. That wasn't at all a comment about Connecticut. And in that report, they really did find that the IRS 990 was insufficient, that it really doesn't capture the kind of activities. And we had been meeting with the Hospital Association, has several, or at least two groups, I think, who are working on community benefits or community reporting. And in several conversations, we had heard from hospitals that there were challenges in their reporting and being able to detail exactly what they've been doing. So sort of insufficient ability given the structure of the form and the ability to do narrative, which is very limited, particularly on community building activities. So, I mean, I think that's up for discussion, how we do the actual reporting. I think that's going to take some conversations with the hospitals and other stakeholders on how to capture it appropriately, whether it's the 990, we do get the 990, but whether it's the 990 plus some narrative or the 990 plus more. And I think the real concern here for us on this is how the CHIPS, the health improvement plans, tie back to the community health needs assessments, because that's the part that came in with the Affordable Care Act, which was how the implementation of the community benefits strategy aligns with the needs that are discovered in the community. Not saying they don't, but the reporting does make it really hard to see what that alignment is. And we are hoping through this bill to make some better and more sufficient reporting requirements that will outline that for you. And also, as the GAO notes, the public, who has, I think, the right to know what these investments are and how they tie back to the CHNAs. On the second part, if I remember right, I think the testimony is relying on already collected information, which hospitals already collect. So hospitals today, and it's probably a good question for CHA or any hospital that might come to testify today, but I think they had also testified in the context of 6424 that 90 to 95% of them have already collected REL data. And I think, as I said last week, as a condition of federal law. So there are already requirements under federal law to capture that. So I think that's, and I hope Universal Healthcare Foundation will testify, but that's one of the things is you can use the data already required. That's the point. And it goes back to the same point as before, which is use that existing data to help improve the health of communities. And so REL data is relevant to that as already collected, not new data, already collected. Other things identified in the needs assessment. Those are the things that are supposed to be targeted for community health improvement and community building activities. We think it'll be much better for you and the public to see how these activities are reported out when we negotiate the actual reporting language.
Just a quick return to the first subject. It seems to me that what you're looking for is more in-depth information about what nonprofit entities have done in terms of helping the community, which is typically the kind of stuff that is put out in people's annual report, report to corporators, board of directors, et cetera, saying we had program A, B, and C that reached out to the Black community, the Latino community, the Asian community, et cetera, and here was the impact. It seems there should be a fairly straightforward way to be able to capture that data in essay format, because all the hospitals I've ever been associated with typically put that information out in a variety of settings in terms of news releases and annual reports. So
yeah, we're just asking for, I think we're asking for a little more detail on how the implementation strategy aligns with the needs assessment, and to make it clearer and more uniform. I think you're right. The information is out there. We're not suggesting also that the hospitals don't provide a significant amount of community benefit, because they do. It's a level of transparency and uniformity that makes it available to the public and shows how these investments are tied to improvement in community health, which is really the goal. And I think the ACA just added a layer, and we kind of never got around to updating it. But there's now a lot more work going on in this space, including the hospitals and other community organizations and advocates around the state. And I think it behooves all of us to have that information out there. And I don't think it will be as difficult when we're done negotiating it as it may appear. And it is not our intent to put an extraordinary burden on the hospitals to do this. So I think we can find a way forward.
I appreciate that. Thank you. And thank you, Mr. Chairman.
Thank you, Representative. Commissioner, are you aware of anything in the relief package that's on the president's desk that would also impact the ACA related to this?
I am not. I hope somebody will tell me if there is. I am not. There are other things related to the ACA that are in the relief package. But I'm not aware of anything that would directly impact community benefit reporting.
All right. Well, at the very least, it sounds like there's still an opportunity for a continuing dialogue with the association and the hospitals. And we're glad to entertain any revisions you might require in order to come to an accommodation with them. I don't see any other questions. We're letting you off real easy today, even with your audio difficulties.
Yes, and I'm very sorry about that. Appreciate the accommodation.
If that's the worst glitch we have today, we'll do just fine. Thank you. Next up is Senator Champagne, followed by Commissioner Sheff. Is the senator available? I see him. There we go.
Sorry, I'm running a couple different meetings.
As are we all. We appreciate you being here.
Yes, we are. I want to thank this committee for taking up one of my bills, Senate Bill 102, and turning it into a committee bill. This is the certification for mental health first aid training. And, you know, nothing that we take up as a legislature should have one source. And this has become very expensive for fire departments. And I just wanted to come on and thank you for taking it up. And hopefully this makes it to the floor and we pass it, because it'll save us a lot of money. And that is basically my statement. Thank you.
Wow, that's very straightforward. Thank you, Senator. And yes, we appreciate your having submitted the bill, and we felt it was a good one for us to consider. Senator Abrams has a question for you.
Go ahead, Senator.
Hi, Senator. Not a question, but we were working on this in 2020 before we had to leave, because we did hear from a lot of municipalities, and I know that you're involved in municipal government as well. And this was never certainly our intention to make it a burden on anyone. So we appreciate you bringing it back up, and we're ready to work on a resolution for it.
All right. I think I just missed your entire question.
That's okay. Don't worry.
Everybody was freezing up on this one, so I apologize.
No, that's okay. I was just saying that we were already working on this in 2020. So we were happy that you brought it back up, because we realized that it was an issue with a lot of municipalities, and it was never the intent, obviously.
Right.
So we're ready to correct it, because the intent of the bill to get that kind of mental health training is important, but it's also important that we do it right. So thank you.
No, thank you. Thank you so much.
Thank you, Senator. And speaking of corrections, Representative Ryan has just informed me that I made an error earlier. The relief package is not on the president's desk. It's going back to the House for reconciliation. We just want to make sure that everybody in the audience is aware of the process at the federal level. Thank you, Representative. Next up is Commissioner Sheff of DDS.
Good morning, Senators Abrams, Summers, and Huang, Representative Steinberg and Pettit, and members of the Public Health Committee. I'm Jordan Sheff, Commissioner of the Department of Developmental Services. Thank you for the opportunity to testify on Senate Bills number 328, 329, and 397. I've submitted a full copy of my written testimony. I'm going to provide to you today highlights in an abbreviated fashion. Proposed bills number 328 and 329 contain the same three general provisions. The first being the Department of Developmental Services creates a strategic plan to reduce the wait time for services for persons with intellectual disability. The second provision would require OPM and presumably DDS to consult with stakeholders if there is a plan to close a DDS operated facility. The third provision would require DDS to provide advance notice to a person with intellectual disability whose eligibility to receive state-assisted care is to end. DDS has concerns with the lack of specificity in the bill's language, and that each of the bill's provisions, if enacted, would duplicate departmental efforts, as DDS is already implementing many of the requirements contained. DDS has plans to reduce wait times for residential services. Over the last 2 decades, DDS has worked to move individuals into the community with appropriate lower cost services that have allowed more individuals to receive funding for their service needs. DDS has advanced new residential models of service that include community companion homes, continuous residential services, supervised apartments, supportive housing agreements, and our IDASH program, the acronym Intellectual Disabilities and Autism Spectrum Disorder Housing. which is a supportive housing units integrated in larger developments. As well, we have in-home supports that allow an individual to live independently or in a family home. By using these lower cost and very effective high quality models of residential service in place of more expensive group homes and larger congregate facilities, the department has been able to stretch residential funding to provide services for more persons on the residential waiting list. If the intent of this section is to require DDS to substantially reduce its waiting list over a couple of years, then waiting list initiative funding would need to be provided in the budget and annualized over the next several years. Previous waiting list funding initiatives have moved more than 100 individuals each time from the residential waiting list into residential services and required substantial new funding in the DDS budget. The governor's budget proposal does not include wait list initiative funding. DDS already consults with stakeholders when DDS has planned to close a state-run facility, as was the case with the El Grasso Center and the department's Meriden campus. When DDS-run group homes and residences on the Southbury Training School campus have been closed, stakeholders, including individuals and their families, employees, unions, and advocates, were all consulted and notified. Their input was vital in making sure that individuals who were being moved were able to find a comparable, appropriate residential service. While with employees and union input, DDS was able to reassign employees to other DDS-run residential programs that resulted in no employees being laid off. The intent of the third provision is unclear as it references when the ability of an individual with intellectual disability ends, but does not say what type of eligibility it is referencing. If the end of an individual's services is because the individual has not yet reapplied for Medicaid and is at risk of losing his or her waiver status, then DDS already has a system in place to notify these individuals through the DDS Medicaid Operations Unit and through the individual's case manager. If the intent is that an individual's services are ending because that person has been redetermined not to have intellectual disability, then I can assure you that this type of decision is rare. Even if an individual were at risk of losing eligibility, he or she would be notified of a redetermination hearing and would be able to exercise his or her UAPA hearing rights up to and including the right to challenge any redetermination decision in Superior Court. Based on the language in these two bills, the agency believes that we currently have the resources and the systems in place to comply with its general provisions and have been doing what the bill would require as a matter of best practices for the last several years. The department would recommend that neither of these proposed bills are necessary. Senate Bill 397 would establish a task force to study the department's level of need assessment system. Once an individual is determined eligible for DDS services, DDS case managers use a standardized assessment tool to assess each individual's level of need for DDS funding and services, including in key areas of health and medical, personal care activities, daily living activities, behavior, safety, support for waking hours, overnight support, comprehension and understanding, communication, transportation, social life, recreation, community activities, and unpaid caregiver support. Both the LON assessment score and the information collected in the assessment is used to develop a comprehensive individualized plan. While the LON, the level of need tool, assessment is the primary tool for determining the need of an individual, there are further opportunities for individuals and their families to request additional funding and supports to assist with meeting specific needs that may not be measured by the LON assessment. In addition, a review of an individual's LON assessment may be requested at any time to reflect an individual's changing need. As part of collaborative efforts with other state agencies, DDS is moving towards adopting the universal assessment system that is currently being utilized by DSS for assessing individuals in their Medicaid waiver programs and the Community First Choice program. This will allow for consistency in assessment evaluations for individuals receiving social services and would mean that an individual receiving DDS and DSS services would receive one assessment across programs to determine their level of need and what services are appropriate to address those identified needs. DDS continues to work with DSS towards the transition to the universal assessment. However, a timeline has not yet been determined. DDS meets monthly with DSS and public and private stakeholders on the Medicaid long-term services and supports rebalancing initiatives steering committee. That's a mouthful, where the transition to the universal assessment is reviewed and discussed. The department is open to discussing ways to improve the level of need assessment tool and would be happy to engage with stakeholders on suggested changes or enhancements. However, in this difficult fiscal climate, the department would be unable to support any changes to the lawn assessment tool that would incur a cost. It is important for DDS to note that there are already numerous task forces that focus generally on studying individuals with intellectual disability and the programs and services offered through the Department of Developmental Services. To this end, the department would respectfully suggest that the creation of another task force would be duplicative, as this study of the lawns assessment could be shifted to one of the standing task forces already in place. Thank you again for the opportunity to testify this morning, and I'm ready to take any questions you may have.
Thank you, Commissioner. We take your reservations very seriously, but I'm sure you can understand that the community is very concerned and continues to be concerned during the pandemic about their ability to obtain services. And you've mentioned resources in several contexts, talking about stretching your current resources, needing resources in order to do some of the data work. And you've also talked about the prospect of utilizing the system that DSS uses, but you don't have a timetable for that. Could you comment a little bit further on when you expect to be able to accomplish this? Because obviously the need for these bills may depend upon your ability to address some of those concerns.
Thank you, Representative Steinberg. We had begun to fully immerse in preparing for that transition prior to the pandemic. As you can imagine, with Commissioner Giffords' time split, as well as Kate McAvoy's time and attention necessary to the pandemic, that wasn't a priority over the last year. I'm hoping that as we move into ramped up immunizations, that will surface again to the top of our common list. And I'd be happy to follow up with Kate McAvoy to see if indeed she has a timeline in mind and furnish that to the committee.
With regard to resources, are resources needed to accomplish this? And are those things being negotiated with OPM as part of the current budget?
So Representative, you mentioned resources across a couple of areas, so I'm not sure which specific area, because the type of resources would be different. And we mentioned in testimony that if it's with regards to addressing needs on the wait list, that was not mentioned. There's no wait list funding in the governor's proposal. So that would be one conversation. If it's with regards to resources necessary to revise and unpack the level of need assessment tool, I have not had conversations with the administration about that, because the expectation is that we'll move, as is required, I believe, by CMS, Center for Medicaid Medicare Services, to have a single state assessment that we use across multiple waiver programs.
So let me just ask the question in a somewhat different way. You're obviously familiar with the intent of the two bills that you're currently not sure you ought to go forward. In the near term, how do we address those concerns?
Well, so currently, just to give you an idea, DDS is represented at the table for MAPOC, the subcommittee for complex care of the MAPOC committee. There's a developmental disabilities work group. There's an autism spectrum disorder advisory council. There's a behavioral health partnership oversight council. There's a long-term supports and services rebalancing initiative steering committee. There's a task force to increase employment for people with disability. There's a task force to study voluntary services programs operated by the Department of Children and Families, who we partner with as the primary mental health agency for youth in the state. There's a task force to study the needs of individuals with intellectual disability. Those are the legislative standing committees. There's also governor's councils, task force on housing supports for vulnerable populations, the governor's council on women and girls, and the committee on employment for people with disabilities. So I think we have a lot of tables where we could have these conversations at that level. In addition to those very formal structures, we have a lot of informal activity where stakeholders can provide input through our regional advisory committees, as well as the DS Council. So structurally, there are a lot of places we could have those conversations. The fact of the matter is we work on those things as a matter of business routinely. We get feedback on the lawn tool, when it's working, when it's not working, and we have made some modifications at different periods in the history of that tool to accommodate some of that feedback. Our IDASH program continues to find creative housing opportunities for people in the community. So we can start on that now. If there are constituents who wish to have a more formal conversation, My office has not turned down the opportunity to have a conversation with someone who is interested in making the department move forward. So we would welcome that without any legislation necessary. If people want to talk about an area of concern, the department's ready and willing to engage in that process.
Thank you, Commissioner. And you're right. It does sound like there are a number of groups that are looking at this. I guess we would ask, we'll hear testimony from others as to the need for this legislation, but at the very least, we hope we can count on you to, as you say, be very cognizant of the concerns this community has had, and through the various venues that you described, continue to focus on those aspects such that at the very least, there's very clear communication as to the agency's plans going forward.
Thank you, Representative. We'll work to assure you of that.
Thank you, Commissioner. I don't see any questions. So thank you for your time today and for that of your staff. And my guess is we may be talking about this a little bit further down, but that's great for today. Thank you.
Thank you, sir. Thank you, everyone.
Next up is number 11, Gina Frankel. I'm sorry. Yes. Gina Frankel. A couple of people who aren't here, hopefully be back shortly. Ben Shakin is number 12. We'll see if he's going to be next. But first up is Gina Frankel.
Okay. Hi, can you hear me?
We can hear you just fine. Please proceed.
Okay. I'm testifying today regarding the Senate Bill 100, an act concerning intersex persons. I'm the parent of a child who could be affected by this bill. While I support the committee's intent to strengthen the rights of intersex persons, I do not support allowing personal medical decisions to be made by a politically appointed task force. My child was born a female with all the appropriate anatomy and chromosomes associated with that gender. However, because she has a condition called congenital adrenal hyperplasia, CAH, she was born with ambiguous genitalia. I respectfully disagree with the committee's broad definition of intersex as it pertains to my child. The prefix inter means between, so therefore the word intersex implies between genders. She is not and never was between a female and male gender assignment. She's a female born with a condition that required medical intervention, including surgery. Our decision to have surgery for her was based purely on medical advice from our endocrinologist and our pediatric urologist, as well as our own judgment as her parents. It would have never occurred to us to have to consult with anyone else, let alone politicians with absolutely no medical expertise at all. Our daughter's health choices should never be up for debate by anyone but us and her doctors. I cannot imagine how difficult my daughter's life would have been had we not been allowed to get this surgery for her. For starters, because her vagina and urethra shared the same channel, the risk of infection was high and could have caused her long-term damage later in life. In addition, because her genitalia was malformed, the surgery spared her from embarrassment, low self-esteem, and even negative impact on future personal relationships. Thanks to proper medical care and the freedom to make these choices for her, she leads the life of a healthy, normal female to this day. If this bill had existed back then, that freedom would have been taken away from us. Furthermore, we don't know if she will require any more corrective procedures going forward as she nears childbearing years. Does the committee really think it's appropriate to weigh in on these potential future personal decisions? Her condition is purely medical and has absolutely nothing to do with intersex or transgender issues, which is what I think the committee is trying to address. My daughter and all patients with CAH should not be lumped into this broad and incorrect definition of intersex. I humbly ask that Section 7 of this bill be removed and/or that patients with CAH be included from it in its entirety. Thank you.
Thank you for your testimony and for your personal story. The title aside, is it possible that there could be people who feel differently than you and your husband do about this, and they should be afforded the opportunity make these choices. I want to add, before I give you a chance to answer, that it's not the intent of this committee or the legislature to make decisions on behalf of the individual. Government, in this case, is once again trying to clarify and enable. So I just want to be clear on that point. But if you'd like to answer, we are trying to address the breadth of those who may fall in this category. To your point, if we remove section 7, you would then be supportive of the bill?
Well, quite frankly, I don't want to delve into an area that doesn't pertain to me personally. I don't think there should be a bill. I don't think government should have anything to do with people's personal choices, regardless, transgender, intersex, CH, whatever. But I'm here today to speak specifically about our situation, which as a parent of a girl with CAH, and I just don't believe that CAH should be a part of this bill at all. If the best we can get is a removal of section 7, so be it. And to answer your first question, I doubt very, very much that any parent of a daughter with CAH would feel differently than my husband and I do. Obviously, I can't speak for everyone, but there's an entire foundation called CARES that advocates for people like us, and it's got tens of thousands of members who share our views. So, by the way, my husband is here and he has a statement as well. I don't know if he got into the.
Yes, he's in the queue and he's not far behind you, so he'll have
Okay.
an opportunity.
Okay.
Thank you. Representative Betts, followed by Representative Pettit.
Thank you very much. Thank you, Mr. Chairman. I certainly concur with your overall view about the government not making personal decisions about your children, your family. I've consistently said that's an overstep, but I would urge you to contact that association and other members who share your view to let the committee know about it, because we've heard this in the past and there has not been a lot of opposition to it. And I think we really need to be educated on the impact of what's happening with this bill and learn how people view this, because absent that, people will assume that there's no real major objections. And that would really be highly unfortunate, I think. So I thank you for testifying. Look forward to hearing from your husband. And again, thank you for sharing your testimony.
So may I just respond to that, please?
Go ahead.
Is it okay? Right now, you can probably tell I'm nervous and I'm uncomfortable. There's a stigma attached to this condition, and therefore it does make it difficult for people to want to speak up about it. For example, even now, speaking today, I'm worried, what if our names get out and then suddenly people find out who our daughter is, and now she's going to be stigmatized as a chick with a you know what, and that's the world that we live in. So it's no wonder that more people don't speak up about it. This is highly personal. All the more reason, really, politicians should have nothing to do with it.
I thank you for that clarification, and I'm super sensitive, as I'm sure everybody on the committee is, to privacy, and certainly I can't imagine anybody on the committee using names or referring to anybody on this. It's just more people could send an email without getting into details and just keep it very simple and say, we oppose this, and keep it very general, where you say, we think it's an overreach by the government, or we don't support the government intervening on this. You don't have to go into enormous detail about it or specific detail. So trust me, none of us are going to go out and start using people's names. And I fully appreciate the sensitivity of that.
Thank you.
Thank you, Representative. And I will only reiterate what the representative said. That's certainly not anything that anybody in this committee would do. Next up is Representative Pettit, followed by Senator Abrams.
Thank you, Mr. Chair. I think more of a statement than anything else, and thank you for your testimony. I think you're absolutely correct in that Section 17 in this bill, you said in your family there is no intersex. It's an uncommon endocrinologic disorder. In my former life, I was an endocrinologist, but the definition in Section 17 here says, as used in this subdivision, This refers to someone born with a reproductive or sexual anatomy or chromosome pattern that does not fit the typical definition, which does not include your daughter. So in essence, this statute does not apply to your family, but I agree with you completely that this is a complex area that's evolving given what we're learning about genetics. And the more we leave it into the hands of the experts, the endocrinologists, geneticists, and other people that you're working with on a regular basis makes more sense. So I really appreciate your bravery in coming forward to make these statements and stand up for what you think is correct. And thank you. And thank you, Mr. Chairman.
Thank you, Representative. Senator Abrams.
Thank you, Representative Pettit said some of what I was going to talk about, but I want to thank you so much for your testimony today, Ms. Frankel, but also I'm wondering if you could tell me the name of that organization again.
Yes, it's CARES, CARES, all capitals.
Okay. And what does it stand for? Just so in case there's more than one, I find the right one.
Congenital adrenal hyperplasia research, education, and support, I believe.
That's very good. Thank you. That's impressive. So thank you so much. I really appreciate you sharing that information with us, but it was also my understanding that, and I will check further, that this bill would not apply to your situation, but thank you for bringing it to our attention so that we can make sure and check into it.
That would be great. Thank you.
Thanks.
Thank you, Senator. Seeing no further questions, again, thank you for testifying today. You've alerted us to this. We're going to read the bill once again very closely to make sure that we've either addressed your concern or it's not actually present in the bill. But we take your point very seriously. Thank you. Next up is number 12, Ben Shaken, followed by we may go all the way to number 21, Christian Eason. Let's see how it goes. Ben, welcome.
Thank you, Mr. Chairman and members of the committee. Good morning. My name is Ben Shaken. I work for the Connecticut Community Nonprofit Alliance. We're the statewide association of community nonprofits who, as members of this committee are well aware, provide essential services in every city and town in Connecticut to more than 500,000 people in need across the state, employing about 14% of Connecticut's workforce. I want to thank you for the opportunity to testify today. I will be submitting written testimony on a number of bills on your agenda. I'm going to try to focus on briefly on two for my my spoken comments today. The first is Senate Bill 102, an act concerning the certification of mental health first aid training programs. We are opposed to this bill as it is currently drafted, and I want to explain why. First, we applaud the legislature's past efforts to address mental health crisis by codifying mental health first aid training in statute in the past. Most recently, I think in 2018 or 2019, to require mental health first aid training for paramedics. Senate Bill 102 would weaken the requirement in statute, and because it allows for mental health training programs that are not approved by the medical community. So just quickly, just like CPR helps a person who has no clinical training assist someone following a heart attack, mental health first aid training helps someone assist someone experiencing a mental health crisis, such as contemplating suicide. In both situations, the goal is to help support the person until appropriate professional help arrives. And because of that, this training is indispensable for paramedics as well as all other first responders, also clinicians, doctors, nurses, teachers, and lay people, just like CPR. Senate Bill 102 would adjust the language in existing statute to give the Commissioner of the Department of Public Health the discretion to designate a different program than mental health first aid to provide behavioral health training for paramedics. And as drafted, the bill wouldn't give the Commissioner any direction about what the characteristics of such a training would be. And so we urge the legislature to amend the bill if it's to move forward to fulfill the original intent of the legislature when it added the requirement for paramedics to receive the training. So I have some language that I will submit in my written testimony that would accomplish these goals. But the thrust of it is to only permit the Commissioner to approve a different training that is peer reviewed by the medical community. And so that will guarantee that there is a high quality training afforded to this group of Connecticut first responders. And members of the committee who were here last year will recall this conversation happened several days before the pandemic shut everything down, and we were beginning to have that conversation with the Paramedics Association then. Secondly, and as briefly as I can, Senate Bill 397, which is the bill that regards the level of need assessment for people receiving services from the Department of Developmental Services. We submitted comments on this bill, or we will be, for the committee's awareness, if they are not already aware, that the level of need score is more than just a level of need assessment. It is in fact very directly tied to the rates that community providers are paid to deliver services to people with intellectual and developmental disabilities. So as the committee considers making changes to the law or directing DDS to do so, which this bill does, we just want to urge the committee to be keenly aware that any change that is made will have a direct impact on what community providers are paid to deliver services. And so as such, we would ask that the committee very much include community providers in any conversations about changes to the law. I hope I've done that within 3 minutes. That concludes my my testimony. Thank you very much for your consideration of these issues.
Thank you, Ben. Let's address the comment you just made. You're saying that any change we make with regard to that would have a direct impact on reimbursements. I'm not sure I understand. Could you clarify?
Sure. So the level of need score is an assessment and screening tool, and people who have IDD are given an assessment by their care team, and the results of that assessment result in them receiving a score, if you will, between 0 and 8, 8 being the highest level of need. It includes things like health and medical, personal care activities, daily living, behavior, safety, etc. It's then used to sort of develop this individual plan with the person's care team. Then, however, if someone's level of need means that they require services from the Department of Developmental Services, which generally means that they are going to need services from a community provider, whether that's day services or employment support or residential support in a group home or another setting. They are sort of assigned a rate based on their LON score that a provider would be reimbursed for providing that service. So I'll give you an example. If someone is a LON 6 and they are living in a 3-bed group home, their annual rate is $121,895. And so that's how directly the score is tied. If they're a LON 7 and they're living in a group home of the same size, their rate is $139,148. So my testimony will, and I'm sorry I haven't submitted it yet, I will append it with the full chart and the full PDF document from TDS of all the different rates. But basically a provider is paid for services based on the level of care that someone will need. Obviously, someone with higher needs requires more care and therefore is paid more, and someone with less may require less care. All of which is to say, when we start considering tinkering with the law, which is something that has merits for sure, that idea, doing so will also require tinkering with the rates that DDS pays community providers to deliver services.
Thank you for that explanation, and we will look at your testimony with great interest. And obviously, we need to be very sensitive. Reimbursements across the board for healthcare are a big issue in the state. So thank you for sensitizing us to that. With regard to your first comments, actually, I can't remember my question. I'll have to leave it at that. I'll catch up with you later, Ben. Seeing no further questions, we do. Representative Dauphiné.
Hi, thank you, Mr. Chair, and thank you, Ben, for your testimony. I'm very familiar with the law and what you spoke about. I have a daughter with special needs, so I understand. I thought for the purposes of this meeting and elaborating on that a little bit, I know that you described the difference in cost, but can you get a little bit more particular? Because we know that someone with a LON of number 10 per se, or what's the top number? Was it 8?
Yes.
8. might be wheelchair bound and might need to be fed and might need to be turned at night and might need every 2-hour medication. Or I think if you get a little bit more specific, it really helps in the details of how that might differ from someone who's a 2, for example, who's independent and can go to the bathroom on their own and those sorts of things. So I thought that description in a little bit more detail would be a little bit helpful to describe how important that lawn number is.
Yeah, I think that's a very good point, Representative, and thank you for the question. The lawn is, I don't want to come off as sounding like the Alliance is opposed to evaluating and making any necessary changes to the lawn system. It's a very complicated analysis that involves a lot of the things that I described in my answer to Representative Steinberg's question. And then all of those things are sort of put together, and what comes out of it is a score between 0 and 8. And obviously there's nuances and there's an individual plan for every person. And so nothing is completely set in stone. There's the ability for TDS certainly has the ability to adjust funding as needed for different services. But it's definitely sort of the fact that it is then sort of tied to rates is definitely makes it like an imprecise and imperfect way to assess people who have very complicated and unique needs. And the fact that it is then sort of coupled directly to rates creates, I think, the conflict that the proponents of this bill, this isn't the first time we've seen this bill, are trying to address. So I think what we're saying is, first of all, as you work to address this as a committee, please include us, because providers will be affected by changes to the lawn system. But then also, this bill as it's before us today is just a proposed bill. And so the next step in your process, if you so choose, will be to draft the bill. And our second request, sort of based on how the lawn system is set up, is that as the committee, if you decide to draft the bill moves forward, that you don't try to move forward sort of within available appropriations. That if our goal is to uncouple the lawn system from rates and to create a better assessment tool, that that trying to make such a thing budget neutral is not going to be possible. That the only way to change the system to better serve residents of Connecticut, to better serve people with disabilities, is to create a system that serves them better. And to do so, you need to not, or it's our opinion that you need to not restrict yourself to only using the funding that you have in the current budget and within available appropriations.
Thank you, Ben. I thank you for that. And I think the one thing I'll add to that is it can really make a huge difference between having perhaps a staff member that would be one less staff member or 2 less staff members within a facility that's doing care for individuals with special needs. So I've seen it be quite impactful and devastating to some facilities that are caring for individuals with special needs. So anyway, I appreciate your comments, and thank you, Mr. Chair.
Thank you. I don't see any further questions. Again, we look forward to seeing your written testimony as we contemplate whether we'll move forward with this bill. Much appreciated.
Thank you.
Okay, we now have a little more clarity on who's up next. We have number 10, which is Laura Lynn Lewis, followed by number 14, Matt Frankel.
Good morning. Can
Good
you
morning.
hear me?
Yes.
Good morning,
Good to see you.
Representative Steinberg. Nice to see you, committee members. Hopefully I can shed some light on some of this that has been discussed this morning. You received my testimony, so I won't read it word for word, but I'm glad there's a little discussion around all of this. Ben mentioned the budget and how it would affect providers. But at the end of the day, all of this system is built to provide for clients and the families that are impacted by the decisions that are made. So I'm here really to underscore the concepts that I asked for in my testimony. And the lawn, I think just before everything shut down, you might have been my last conversation, Representative Steinberg, about this lawn bill. And at the time I mentioned that we weren't looking for a task force, but that we did want we wanted a committee shaped around this universal assessment that we hear or understand that is coming. And the reason for that is because there have to be families that can appropriately speak to the different levels of need when we go forward with all of this. The commissioner talks very nicely. We're very pleased to have him in that role. But the reality is that there have been numerous commissioners in the 30 years that I have had dealings with DDS for my son. And they are not all created equal, sadly. And so if we're not here paying attention, they can say, they can give their testimony to all of you, and you don't really know any different. And so the commissioner this morning referenced the last 2 decades. Well, just to give you a snapshot of 2012 with a different commissioner, he testified in front of appropriations and referenced the 500 on the residential waiting list. And since 2012, we are now up to just over 2,000, and it has been hovering at the 2,000 mark for a number of years. So this is a much more complex system and issue, and we're here to make sure that families are represented and families are appropriately protected. And so the 2 concepts that I've raised in my testimony, I hope that you'll all take a look at and you'll all strongly consider. They are concepts that have passed out of this committee previously. So not only in addition to the committee for the level of need, the universal assessment, the reporting the reporting that I'm desiring to be attached to the 12, what was it? The Public Act 1761 that you all passed a number of years ago that requires You hit your 3-minute mark, if you wouldn't mind concluding your remarks. Sure. So the statute that requires the census on the residential list, waiting list, doesn't actually ask for DDS to provide that information to all of you. And I think that's a very critical missing piece. So I hope you'll consider what I've written. I look forward to speaking to all of you at another time, and you certainly can reach out to me with any questions.
Someday I'll get that mute function down. Thank you, Laura Lynn. You have been absolutely consistent with your advocacy, and we appreciate that. It seems like we may be at a little at cross purposes, but we don't necessarily need to be. You say that you don't really need to advocate on behalf of another committee or working group. It's more or less the specific communication that you're looking for in terms of transparency, so that if we mandated that the agency provide that information through whatever auspices, you would be okay with that?
No, I'm talking about 2 different things.
Oh,
One,
okay.
the data from the residential waiting list that they have to do annually, that doesn't get reported directly to the Public Health Committee, the Committee of Cognizance. And I think that is a huge piece that is missing in Public Act 1761. That's the first thing. The level of need bill, we're not asking for a task force, but we are asking for family representation to whenever there is this universal needs assessment that's going to go forward in Connecticut, that however that is structured to begin, that we want representation at that. And the only way we see that happening is some level of a committee, whether that's internal with DDS. I don't know how that would be shaped, but the bottom line is there is a level of need of 1 through 8. And we were up here and asking for a whole new assessment a number of years ago. And it made it through committee, it made it through the Senate, and it didn't get called in the House because one of your colleagues was concerned that if we had a new level of needs assessment, that it would end up showing that we actually have many more in the higher level of needs categories, and that would require more funding. And so it never got called in the House. Not a good way to do this, but we've learned that trying to go up against some of that is futile. So we are simply asking that, since it is going in this direction of the universal needs assessment, that we at least are represented. And I would like to just give a quick snapshot of why. For me personally, and we hear stories from families all the time, and it is important that DDS can tell you that more than 50% of the population that it serves is the higher levels of need. They can say that to you today. I think people get very comfortable hearing the flattering stories of, look at what the population can do, they can live independently, and it's a wonderful world. But reality is more than 50% have higher levels of need. And in that, the current assessment, one of the areas they look at is safety, and they score you in the safety. My son was really kind of the poster child for independence. A number of you have met him. He's been up at the LOB in the Capitol with me over the years. But just in the 11 years that he's been away from my home, he has gone from living in various settings, a studio apartment independently, a condominium with a roommate, and he is now in congregate care. So his needs have changed that rapidly. And the key piece that got him needing the congregate care is safety. And his own case manager said to me, you know, this level of need assessment doesn't even capture what is going on with your son. And it doesn't. My son engaged with an online predator, and this online predator passed himself off as Child Protective Services. He stalked my son. My son had no idea. He would have been able to tell you stranger danger and how to avoid it a number of years ago, but he engaged online. He gave all his personal information. And that is just one example of a handful of very serious safety issues surrounding my son that has taken him down this path of much higher needs that weren't captured by this assessment tool. We talk to families all of the time with different needs, and their children, some are medically needy, and they have said the questions on it don't reflect their child's needs. So again, I'm not here today to ask for a new assessment tool. But I am asking that if the direction that we're going in is a universal needs assessment, that we at least, the stakeholders, families that are served by DDS, as Ben Shaken said, it definitely affects the providers. We have a wonderful relationship with our providers because the providers take care of our kids. They are necessary. We couldn't do it without them. So we want to make sure our children are taken care of, but we want to make sure that the providers that take care of our kids are also protected. So any committee would include providers.
Okay, Orlin, we take your point. There are a number of people here with questions. I will just say, I think we all share your concern that the assessment may not reflect accurately the acuity levels and recognize as well that for over a decade, we have been not funding this particular area to the degree we could, which means that if we acknowledge greater acuity, we're serving fewer people. And that's sort of the core problem that we continue to address as a state. Representative Miko, followed by Senator Abrams.
Thank you, Mr. Chair, and thank you, Laura Lynn, for being here. And nice to see you again from a
Nice to see you
distance. So I just wanted, first of all, I haven't had the benefit of being able to read your testimony, but I will. So I apologize for that. But I just wanted to ask you with regards to the residential waiting list. Would you care to speak about that a little bit?
Sure. Sure. So most of you didn't know anything about the residential waiting list until we stepped foot in that building, unfortunately. We're a population of 17,000 that get served by the DDS, and without representation in the buildings that you are working in, not presently, obviously, little was known. And there's enough turnover among the legislature that even when we do begin to educate some of you, you don't run again. Some of you don't run again. Some of you are not reelected. And so we constantly go around and around on this wheel. And it's very easy for commissioners to sit in front of you and tell you this nice story. And it's easy to just check it off the list and move on. But our families are affected by the decisions that you all make, by what the commissioners put forth every single day of our lives. And there are some real needs. And as families, we hear those needs. You might not necessarily as legislators, but I can tell you, marriages break up because of the ongoing stresses. We have parents that are sitting in their cars in their driveway on a cold February night because their kids are pummeling them. They've just returned home from an emergency room, and the only way for a parent to make sure that their kids are safe, but they're not being hurt, is to leave their adult child in their home and sit out in their car for several hours to let it all de-escalate. I could fill you with so many stories, but the problem is the need is there. And so when we're not in the building in 2012, then Commissioner Macy testified in appropriations and said, there are 500 people on our residential waiting list. We have gone up to over 2,000. And the only way that any of you are going to be able to really keep an eye on that is to pass this legislation that I'm asking for in my testimony to require the agency, whether it's this commissioner 5 years from now, 10 years from now, to report the data from this residential waiting list census directly to your committee prior to every legislative session. That protects families. That begins to protect families. That begins to protect the clients, because then you at least have a firm base to look at, to see what the needs are. And then you can go from there, whether there's testimony that year, whether there's the commissioner giving reports on it. You're seeing the result of the bill that you all passed for us a number of years ago, requiring them to do an ongoing census of every family's needs and compile it. But it doesn't do any good if that data sits on their website and doesn't make it to all of you. So because you're the Committee of Cognizance, I can't imagine anything more important that you could all do than to make sure that makes it efficient for all of you. That protects clients, but it makes it efficient for every committee member on public health. But we'd go one step further and ask that it also be provided to the Appropriations Committee, because obviously they really need to have firm knowledge of the data so that they can ahead of each session, so that they have an understanding where they need to go in the budget.
Well, thank you for that explanation, Laura Lynn. And if I may, Mr. Chair, just one more question, and hopefully the answer to this will be brief, although it's not really a brief topic. So you mentioned appropriations as the next logical step. So would it be fair to say that the waiting list problem simply comes down to money or lack of money allocated by the legislature, or does it go beyond that?
No, that's key right there. But the commissioners serve at the pleasure of the governor. And so they can't really come in front of you and ask and tell you that they need money. So this is a nice way to get around that is, okay, at least you will have the data in front of all of you so that you can add that layer of protection for the clients that this agency serves.
Okay, thank you. I appreciate that. Thank you, Laura Lynn. Thanks, Mr. Chair.
Thank you,
Thank you.
Representative. Senator Abrams, followed by Representative Betts.
Thank you so much, Ms. Lewis. It's nice to see you. A lot of what I was
Nice
going
to
to
see you
ask
too.
you, you've answered, and I totally agree with you in terms of having that information available. I know that I serve on a CROPS as well, and we're always asking for that. But I think you're right. We shouldn't have to be asking for that. It should be provided before the legislative session. So I appreciate that. I just wanted to ask, the one thing that wasn't asked of you that I wondered is in the current level of needs evaluations, are parents a part of that? Are you allowed to give your input or is the evaluation happen without your input?
It really depends case by case if the families are around and they're attending the meetings, and for the most part they are. You can weigh in on it, but it's very specific questions. The answers are essentially 1 through 4, very, very much needed, somewhat needed, not needed at all, that kind of thing. But if the questions are not appropriately there, if they're missing, if key questions are missing, then you're not getting the accurate picture. And the case managers can write in notes, but that's only as good as the case manager that you have. And the bottom line is, and maybe you've heard this time and time again or not, but the case managers are not all created equal. The training, that's another issue for another day, but the training for case managers is not even and equal. And so one family might get an outstanding case manager that really knows their stuff, that knows how to work it to make sure that client is going to get what they need. And there are other clients that, good luck. And I can give you one quick example. When my son was getting ready to go transition from the school system over 21 into the DDS system, they gave us a new employee who was directly from birth to 3, who had absolutely no knowledge of what my son needed at age 21 to go forward. And imagine sitting at a meeting with everybody that serves my son, and my son with Down syndrome actually knew more than this employee. So that's just a snapshot. I could tell you, I could fill your days with story after story. So that's why you're there. That's why we're asking for the little bit of help that you guys can do for us, and I hope you will.
Well, thank you so much for your testimony and for always helping us do better at this, because it's certainly our intention. And so I just so appreciate your advocacy. Thank you.
Thank you.
Thank you, Senator. Representative Betts.
Thank you, Mr. Chairman, and good to hear from you again, Laura Lynn. I have a
Nice
couple
to
of
see you.
questions. One is, have you shared your desire with the commissioner about having parents of these DDS clients, if you will? Have you shared the idea of being part of the process to examine the universal assessment?
Not specifically. We've talked about the need for a different level of need assessment, and he's willing to have those conversations. But what we have found, and I know you and others don't really like to go the route of legislation if you don't have to. And we certainly got the message loud and clear about task forces. But as I said, there's been enough turnover with different commissioners and employees that unless it's in legislation, we are not protected. So let's say the current commissioner ends up having some kind of a crisis, as the former commissioner did, and leaves. The conversations that we have with this particular commissioner will be null and void. And there's going to be, if we move in the direction of a universal needs assessment, that's going to be around for years. I might not be around for years. Other people that might be interested right now in serving on that might not be around at the time. So because this population is not going away, because there's always going to be some level of an assessment, we would like to, if we're going to change now from the current system to a new system, it seems logical, and I hope you all agree, that we do need parents that can accurately represent those levels of need 1 through 8.
Okay, thank you. The reason why I mentioned, sorry for the dogs in the background, but the reason why I mentioned it is he may very well agree with you. And that would make a big difference in terms of moving this bill forward. Thank you very much.
Thank you. Appreciate it.
Thank you, Representative. And now that the dogs are done, it looks like those are all the questions we have for you today, Laura Lynn, but we look forward to your ongoing input and take your points very, very seriously in terms of making sure the community is engaged in any assessment decisions. Next up is.
Thank you, Representative. Thank you, everyone, for hearing me. I appreciate it.
Thank you. Next up is number 14, Matt Frankel, followed by Doris Maldonado.
Unmute, start. Hello, can you see me, Mr. Chairman? I can't hear you.
We can hear you and see you.
Thank you. 16 years ago, during my wife's second pregnancy, we decided to get a voluntary 4D ultrasound, as a special ultrasound. And we got that so we can get the earliest possible baby photo of our new child. It was through that ultrasound that doctors discovered our baby girl was not developing properly. Indeed, the doctors were not sure whether we would have a baby girl or a baby boy. This led us down a path of home amateur research to try to determine what could be wrong. And during that time, we came across Dr. Maria New and her congenital adrenal hyperplasia, or CAH clinic. Both my wife and I were genetically tested, and it turned out we both had the specific gene deletion. So we knew that we were both carriers of the disease, and so we knew CAH had to be the culprit for her abnormal development. Somewhat ironically, we now also knew for certain we were having a baby girl. And this is because males with CAH do not have the same physiological growth deformities as CAH girls. Psychologically, this was a tough blow. The feeling of excitement and joy at the birth of our second child was replaced with worry and anxiety. Still, we were lucky. The vast majority of CAH parents do not even know there's a medical issue with their baby until after birth. We, however, had time to prepare. Our doctors knew that our baby needed to be given cortisol and Florinef substitute hormones and salt to avoid an emergency and possible death immediately after birth. But we had time to prepare in another way too. We felt a deep sense of societal stigma. Our daughter's condition presented as malformed genitalia. What do we tell family and friends? What condition has caused her to remain in the hospital for weeks after birth? So we remained private. Only a small circle of family and friends knew the complete picture. For everyone else, we developed a series of half-truths such that our daughter's condition would remain confidential. To this day, we refrain from describing CAH in detail, Her condition is a cortisol deficiency and nothing more. I say this to describe to you how difficult it is to discuss this issue in public. The stigma surrounding any issues with genitalia is real. We do not want our daughter to be treated differently or worse, subject to ridicule. Yet the bill you're debating today could do exactly that. Intersex is a complex area of medicine, and my personal view is politicians should have no role in its definition or medical treatment. With all due respect, you simply do not have the expertise. But that's not why I choose to speak today. Today, I want to make one simple point. CAH is not an intersex condition, and any attempt to legislate medical choices should expressly exclude CAH children. Our daughter is a girl in all respects. She's 15 now. She has the same XX chromosomes as every other woman.
XY.
Her breasts are developing just like other teenage girls. She has a vagina like every other woman, but there's a subtle difference. Due to miraculous surgery, her genitalia and vagina now work properly. Can it be that a task...
You hit your 3-minute mark if you wouldn't mind.
Can it be that a task force made by politicians, indeed possibly made up of politicians, should have the power to force a child to live with a birth defect merely because the defect involves sex anatomy? Can we imagine a bill that would require a political committee to determine whether or not fixing a cleft palate was medically necessary, perhaps only partially medically necessary? Fix a child's nasal cavity while leaving a disfigured nose? It defies imagination. Yet, if this bill passes, CAH girls and their parents might need to confront this reality. And this is not just in Connecticut, this is going on in other states as well. So I understand that there's pressure from the left to allow children to make decisions for themselves when they're old enough. And I get that there's a general feeling that they should be sympathetic to people that really identify and live as intersex. And there's probably pressure from the right for the government to
Sir, we've asked you to try to conclude your remarks. If you could do so, please.
We'll do so. But my views on whether or not that is appropriate in some circumstances or no circumstances is not important. But for CAH girls, such intrusions are never appropriate. After spending almost 16 years with our wonderful daughter, it is sometimes difficult to remember the stress and anxiety caused by her condition. Indeed, we continuously worry that one day she may have a cortisol event and will not be delivered in time. CAH is a very
Thank you for your testimony, sir. You've gone way over the limit. We've asked you to try to conclude in 3 minutes. We take your comments very seriously. I think you made your point eminently clear. We are going to look at that section of the bill very carefully to make sure that it does not pertain to your daughter's circumstance or anybody else with that specific circumstance.
Thank you.
I do not see any questions. Again, thank you for your testimony today. Next up is Doris Maldonado, followed by number 16, Ann Pratt.
Buenos dias and good morning, Representative Jonathan Steinberg, Senator Mary Daugherty Abrams, and members of the Public Health Committee. My name is Doris Maldonado, and I'm a registered Latina voter in West Hartford. I am here to testify in support of HB 6550 regarding revisions to community benefits programs administered by hospitals. As the statewide bilingual health information specialist for PATH-CT and National Family Voices Cultural Responsiveness Team, I am more than professional expertise as well as despair for the marginalized within marginalized communities. I am a Latina with disabilities, adopted mother of 17-year-old twins with special needs and a thriving toddler. Between my children and I, we have over 15 physical and mental health disabilities, making us immunocompromised. COVID-19 has demonstrated the need and value of local communities' resources to maintaining health in times of vulnerability, ensuring that community benefit dollars address health disparities and social determinants of health, ensures that nonprofit hospitals reinvest stay local, and help to financially support needed community resources. Our family lost 4 matriarchs last year, including my mother. My eldest son, a junior in high school at the time, survived 16 days with a false negative COVID diagnosis right after the world shut down, only to have my mother pass the following month and 2 aunts every other month thereafter. I've had electrical shock treatments twice to my heart and subsequent PTSD, concluding in securing a will and DNR. Health access is an essential human civil right. Access to the vaccine is considered essential, but only for targeted and protected classes as we face survival of the fittest. Our communities remain disparaged by health, housing, food, education, and employment insecurities. Without health, the rest have become a pipe dream, further ostracizing our marginalized. My son and I suffer with very tangible fears of contamination and trauma daily. People with disabilities are perpetually stigmatized as the have-nots in your democracy as we crawl towards tomorrow and the next beyond the 364 days when we were forgotten and remanded to isolation without voice or choice. As a guardian ad litem, certified health worker, infant and youth mental health worker, teacher, faith-based accessibility and inclusion leader, I've advocated for our people through the lifespan and their civil rights in pursuit of happiness. Our holy grail is health. We cannot empower, support, educate, and rationalize the vaccine distribution or any other type of health concerns and rights when it blatantly disregards at least 1 in 5 of us while stacking the disabled, marginalized among the already marginalized. Health, like the COVID-19 vaccine, has been ordered and shipped awaiting consumption at a satellite near you, but delivery for many of us has been stalled and walled. Please help me prevent burying our children or leaving them behind orphaned as I was. Thank you for sharing your privilege. Gracias.
Thank you for your testimony. We really do appreciate that. Your perspective really helps us a lot with regard to this topic.
Thank you.
I don't see any questions, but again, we will consider your testimony very carefully. Thank you for taking the time today. We appreciate it. Next up is Ann Pratt, followed by Neil Dolan.
Good morning, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Ann Pratt, and I'm the organizing director of Connecticut Citizen Action Group, a statewide membership organization committed to a more just and equitable Connecticut. We are in support of HB 6550, an act concerning Office of Healthcare Strategies recommendations regarding the Community Benefits Program. Tying community benefit programs to community health needs assessments tools is a critical component of hospitals serving as an anchor institution in communities, and also can advance health equity by addressing barriers to health. Engaging community partners throughout the process, from assessing needs to developing an implementation plan, is integral to achieving healthy communities. Community partners can provide insight in often neglected areas such as social determinants of health, access to food, affordable housing, education, and areas in which hospitals may be able to play a role in addressing barriers and improving health outcomes. CCAG is a group that's deeply committed to organizing and centering community voices in the development and implementation of policies that improve health, housing, education, and environment, all of which impact our children, families, and communities on a day-to-day basis. House Bill 6550 strengthens the timing, the content, the regularity, and the uniformity of required hospital reporting through creating a community benefit and community building spending floor, requires demographic data to be included in the reporting, and also provides greater transparency by requiring OHS to post hospital reports and annual analysis. CCAG also supports the recommendations to strengthen this legislation by specifying and expanding data reporting requirements including race, ethnicity, language, disability status, sexual orientation, and gender identity data points. And especially in defining meaningful participation to set a standard for soliciting community input and engagement. I cannot stress how important that is given our experiences of engagement of community and the need for it to be robust and meaningful for the institutions as well as for the communities. The pandemic has highlighted how important community resources are to maintaining health in times of vulnerability. Community benefit dollars can address health disparities and the social determinants of health. Thank you for the opportunity to testify regarding this important piece of legislation. Thank you.
Thank you, and thank CCAG for weighing in on this. I think you did a really fine job in explaining the importance of this and the details of it. And I think you didn't stress enough exactly how important it was. So we really do appreciate it. We have a lot to consider with this bill, but it's clear that the intent is something we'd like to see if we can make happen. Devil's in the details, but we're going to be working on that.
Thank you.
I don't see any questions, and thank you again for your testimony today. We're going to move on. Next up is Neil Dolan, followed by Mark Schaefer.
Good morning, sir. Can you hear me okay?
We can hear you.
Good, thank you. My name is Neil Dolan. I'm a resident of North Carolina for 22 years until December of last December 2020. I was a resident of Fairfield County, Connecticut. I'm the parent of a child who would have been impacted by this bill, and I'm speaking in opposition to Section 7 of Senate Bill 100. I'm speaking with some reluctance and trepidation because I am concerned, obviously, with the confidentiality rights of the medical record of my daughter. And I think that this, may intimidate people from coming forward and speaking. And quite honestly, if I was still living in Connecticut, I probably would not be talking to you today. So I'm going to call our daughter Dorothy for the purposes of the hearing. She was born with congenital adrenal hyperplasia. At 1 month, she was abandoned by her presumably biological family at a designated drop-off point, placed in a group home where she languished for 4 years until we adopted her. And we brought her home. And as people know, this all happened because her body is incapable of making life-sustaining hormones, aldosterone and cortisol. As a result of that, she was exposed to higher levels of testosterone while in utero and developed external genitalia resembling those of a male. I don't see this as intersex. If we had given our other daughter testosterone in her formula, she probably might have developed the same thing. We were only home a few months when she started complaining of feeling wet underneath, to the extent that she developed a phobia about going to the bathroom, took her to a urologist, and it was found that because of the configuration of her genitalia, her urine was pooling in her vagina, making her feel very uncomfortable. The urologist proposed some corrective surgery for that, and whether that was
how do I get on cam?
Whether that's medically necessary or not, I don't know if I want to leave that up to an HMO to decide. I feel medically necessary is kind of a way of denying care or triaging it so that people who rely on insurance like myself could not provide that for our daughter. We learned at that time in 2019 that there were legislators that were considering banning the procedure that the urologist was recommending. We were very surprised that legislators would come between us and our daughter's pediatrician. And as a result, we rushed ahead with the surgery in case that legislation would pass. It didn't. The surgery was very successful. Our daughter is a happy, well-adjusted 6-year-old girl. She loves to splash in the bathroom. She has no more urinary symptoms at all. There's no phobia about going to the toilet. And, she recently told us that she, in fact, is queen of the world. So we're thrilled with how the surgery went. We're very concerned at decisions regarding whether other parents in this situation would be able to do this, would be impacted by this legislation. We don't feel that there is a place for the politician in the consulting room between us, our daughter's pediatric team and her. And, therefore we feel very strongly, even though we no longer live in Connecticut, and even though our daughter had the surgery, that other people be afforded this opportunity without political appointees deciding what's medically necessary, or an insurance company in Texas or Florida denying coverage because there is some kind of a loophole in Connecticut legislation that's not in other states. So we would strongly urge the committee to basically put in a complete exclusion for congenital adrenal hyperplasia. Our daughter should not have to go through this to get the care that she needs. Thank you very much.
Thank you, Mr. Dolan, for your testimony. Again, this is a very hard issue, and we certainly appreciate the circumstances that you describe, and we have to be very careful how we move forward with this. I thank you again for your testimony. I don't see any questions for you, but thank you for that. Next up, we have number 17, Mark Schaefer, followed by number 18, Dashni Sadsivam, and I'm sure I did terrible on that. Welcome, Mr. Schaefer.
Good morning, Senator Mary Abrams and Representative Jonathan Steinberg and members of the Public Health Committee. I'm pleased to be here this morning to testify regarding House Bill 6550, an act concerning the Office of Health Strategies recommendations regarding revisions to community benefits programs administered by hospitals. CHA opposes the bill as written. Many Connecticut communities suffer from long-standing underinvestment and structural racism, contributing to high levels of avoidable chronic illness, reduced life expectancy, and health disparities. Hospitals have a long history of investing in their communities based in large part on the community health needs assessments that hospitals finance and conduct with community members and partners. They've played a leadership role while actively collaborating with community partners to formulate and implement community health improvement plans. The language of the bill emphasizes the role that hospitals can play in supporting the improvement of health status of all populations in their geographic areas. In order to fully realize this role, hospitals must have access to statewide healthcare utilization data that can be used to examine the patterns and prevalence of health conditions in their communities and the factors that contribute to poor healthcare outcomes and associated disparities. We ask that this bill provide hospitals with access to the data they need to advance this important work. The bill also proposes substantial and unnecessarily prescriptive reporting requirements that would be both costly and excessively burdensome to fulfill, and that would potentially complicate and disrupt the administration of community benefit programs. Generally, we believe that community benefit reporting can help inform public, private, and cross-sector collaborative efforts. We're prepared to work with OHS to come to a mutual agreement with respect to reporting that balances administrative burden with greater transparency. Finally, we strongly oppose provisions in this bill that would give OHS unilateral authority to mandate community benefit spending levels, a provision that is precluded by the hospital tax settlement and which could result in the imposition of significant financial penalties. These requirements fail to recognize that the greatest responsibility for the community conditions that drive poor health rests with the state, which has substantially and chronically underfunded social services and public health. Hospitals are prepared to partner with the state to solve community health problems, but do not support giving OHS the authority to impose new hospital spending requirements to address what is essentially systemic underfunding of Connecticut's most vulnerable communities. The spending floor requirement also fails to take into consideration the substantial and increasing responsibilities that hospitals bear with respect to uncompensated care, Medicaid and Medicare underpayment, public health, and community benefit investment. Over the past 10 years, hospitals have doubled their community benefit spending from nearly $1 billion in 2010 to nearly $2 billion in 2019. Over this same period, hospitals have invested nearly $3.8 billion in community benefit services, excluding charity care and Medicaid underpayment. They've done this while providing one of the largest sources of tax revenue for the state of Connecticut. Hospitals were the fifth highest source of tax revenue in 2019, paying more than all other corporations after considering corporate tax credits. On a per entity basis, hospitals are among the highest taxpayers in Connecticut. Hospitals have provided nearly $3.3 billion in revenue from 2012 to 2019 to the state. Under the recently approved and legislatively authorized tax settlement, hospitals will provide an additional $4 billion in revenue to the state between 2020 and 2026. In summary, we support the change in authority to OHS, and we look forward to conversations with OHS regarding reasonable enhancements to community benefit reporting. However, we stand in opposition to a spending floor which functions as a tax and is in violation of the hospital settlement agreement with the state. Connecticut's hospitals stand ready to engage OHS, other state agencies, and the administration in substantive discussions regarding these enduring community health challenges and their solutions. We welcome the opportunity to take concerted action in partnership with the state to develop a comprehensive plan to address the drivers of health, health disparities, structural racism, and income inequality in Connecticut. Thank you for listening to my testimony this morning. That's all I have.
Thank you for your testimony. And yes, the Connecticut Hospital Association has made it clear that they have many concerns with this, and thank you for making explicitly clear what those concerns are. For one, I'm alarmed that this would be in any way a violation of the understanding between the hospitals and the state of Connecticut in the most recent settlement. And I'm sure we all want to thank you on behalf of all the hospitals in the state of Connecticut for all the great work you've been doing under pandemic circumstances, and your desire to work with OHS and the legislature in addressing the, as you say, the underserved needs that community benefits are intended to address. I'm at least encouraged by the fact that you see the opportunity for dialogue and partnership, and perhaps we can find a path forward to honor the intent that OHS would like to see happen. Representative D'Amico.
Thank you, Mr. Chair. Thank you, Mr. Schaefer, for coming and testifying today. I was wondering if I could ask you about a different bill that's on our agenda that your organization submitted testimony in regards to. It's House Bill 6298. It's a bill that I introduced having to do with medical diagnostic equipment for people with disabilities. Are you familiar with the bill? Are you familiar with the issue?
I'm not familiar enough to comfortably respond to questions on that bill.
Okay. The only reason I bring it up is because your organization, the Connecticut Hospital Association, did submit testimony about that bill. I take it you didn't have anything to do with that testimony? Is that?
Yeah, I was not actively involved in preparing that testimony.
Okay. Well, I'm going to ask you a general question anyhow, based on that testimony, if that's okay with you. Or would you prefer not?
I think it would be great if you could ask the question. If I can respond, I'll do that. Otherwise, we will come back with responses to your question that aren't addressed in the testimony, if that's workable.
Great. Okay, I appreciate that. Thank you. So the bill 6298 would require the technical standards for accessibility that have been developed by the Architectural and Transportation Barriers Compliance Board be adopted in Connecticut. And the testimony that was submitted by the Hospital Association indicated that mandating compliance with technical guidance would be a costly misstep. So I would acknowledge that it would be costly to try to bring medical facilities in compliance with the recommendations of this board, of this access board. But would it really be a misstep? Would it be fair to characterize it as a misstep to try to make accommodations for people with disabilities? Would that be a misstep?
So I know that for hospitals generally, and I in particular, have been an advocate for individuals with disabilities and accessibility for many, many years. With regard to the nexus between sort of that generally supportive position around accessibility and this bill, I would like to get back to you on that question as to the use of the term misstep and anything further we can say beyond our testimony, if that works for you.
Okay, I would really appreciate it because I would like to be able to work with the hospital association and try to make some progress on this issue, and I'm sure the hospital association would as well. So if we could if you could get back to me and with maybe a little more detail with regards to their position on this, I would appreciate it.
We will do that. Thank you.
Thanks, Mr. Schaefer. Thank you, Mr. Chair.
Thank you, Representative. Representative Pettit.
Thank you, Mr. Chair. I guess we're on 6298. I would add to that discussion when I reached out to some people this weekend on this bill. What I heard was that this perhaps may be under federal purview, that the concept has been around since 2010, but no federal regulations promulgated to 2017. But DOJ and other entities have not done any enforcement under the ACA. So I think we need to sort out whether this is under federal or state purview, and perhaps Mr. Schaefer's and the attorneys at CHA can weigh in on that specific issue concerning 6298. Thank you, Mr. Chair.
Thank you, Representative. I believe we put Mr. Schaefer in a bit of a corner on this other bill. And I have word from others at CHA that they're glad to engage us on those specifics subsequently. So we will get to the questions that Representative D'Amico and you have sought to get answered. So we'll not put you on the spot any further, Mr. Schaefer.
Thank you. It's not a problem at all. And I'm sure we'll be circling back on both those questions. Thank you.
Thank you for your testimony today. I don't see any further questions. We really appreciate it. Thank you. Next up is Sam Liu, followed by number 19, Rosanna Ferraro.
Good morning, Senator Abrams, Representative Steinberg, and esteemed members of the Public Health Committee. I'm Karen Siegel. I'm testifying today on behalf of Health Equity Solutions and in place of Dashni Satasavam because she had a family emergency. So we had to make a last minute switch. I appreciate your accommodation for that.
We're always glad to see you. Typically, we do not allow switching out in this fashion unless we've been previously alerted, but we'll make the exception in this one case. I just want to make it known for, and generally switching out like this is not something we normally do, but please continue.
Very much appreciated. Thank you. Health Equity Solutions, for the record, is a nonprofit organization with a statewide focus on promoting policies, programs, and practices that result in equitable healthcare access, delivery, and outcomes for all people in Connecticut. We strongly support House Bill 6550 and its efforts to align existing processes and utilizing existing data to create a more coordinated, impactful, and community responsive approach that recognizes the work that hospitals are already doing to help address costly health inequities in their communities. Over 14 states in the US have already passed laws outlining community benefit spending requirements and reporting standards, including 6 states that have enacted spending floors that go beyond the federal IRS standards. Connecticut has an opportunity to leverage learning in those other states and to leverage community benefit programs as a tool for advancing health equity. We agree with the 3 very minor changes that have already been spoken about by others, which are defining meaningful participation so that there's a shared and standardized understanding of what it means to solicit community input and engagement in CHNAs and community benefit programs, to specify the demographic data reporting requirements, again, focused on data that hospitals are already collecting and simply reporting population level data to facilitate collaboration and partnership with community-based organizations that are addressing the social determinants of health in those communities, and to solicit public feedback and create a dialogue among the Office of Health Strategy, consumers, and hospitals by hosting a public comment period on the annual OHS report that's suggested here. We have been in conversation with the Connecticut Hospital Association and others, and truly see this as being something that we can reach a compromise on. We do think that from our consultation with other attorneys and from the research that we've done about this in other states, we do not see the spending floor as a tax. I know this is something I spoke to some of you about and have done more research on, because it isn't intended to increase spending rates. It's really looking at What is the historical trend of spending? How is that spending allocated? Can we be more transparent about it? And can we be consistent about what we're requiring across hospitals? So I think that's the intent of it, and think that there are ways to address the concerns that have been expressed by the Hospital Association. So thank you for the opportunity to testify, and particularly for the accommodation given our staff emergency. And I'd be happy to answer any questions.
Thank you for your testimony. We look to you as a critical partner in helping us accomplish our intent here. So thank you. And if you haven't not already, make sure you submit some written testimony. And again, help us try to find a path to making this work for us all.
Absolutely.
Don't see any questions. So thank you for coming in as a late minute pinch hitter. It was important we heard from HES on this. Thank you. Next up is Rosanna Ferraro, followed by number 21, Christiane Eason.
Good morning, chairs and members of the Public Health Committee. Thank you for the opportunity to testify in support of House Bill 6550, which Karen was just speaking on. I'm Rosanna G. Ferraro, Policy and Program Officer for Universal Healthcare Foundation of Connecticut. I've submitted written testimony, so I'm just going to summarize here. We see this proposal as critical because it ultimately comes down to hospital accountability to their community. In exchange for nonprofit status, nonprofit hospitals are asked to reinvest in their communities with the goal of focusing on community health needs, including health disparities, as opposed to simply providing direct medical services to patients. Currently, however, most of the community benefit spending that hospitals report is primarily charity care and Medicaid and Medicare shortfalls rather than community investment. Connecticut currently has no minimum requirement for community benefit spending nor a community building spending floor. Establishing these spending floors, as this proposal does, would create that accountability for hospitals to invest in their communities. Greater transparency is also needed around community benefit programs. Uniform reporting to OHS and OHS's analysis of the reporting are important so that the public can understand how hospitals are investing their community benefit dollars. The civil penalty in this bill is critical because it enforces the requirement of hospitals filing information about their community benefit program. When hospitals hold nonprofit status, they enter into a bargain with their communities. The state must be able to enforce hospital accountability in this bargain. We propose several recommendations to strengthen this bill, similar to what I believe Ann Pratt said to you earlier, that this bill should specify and expand demographic data reporting requirements to include race, ethnicity, primary language, sexual orientation, and gender identity data. The proposal should also define meaningful engagement of community members to set a standard for collecting community input and engagement for community health needs assessments and community benefit implementation strategies. We also think the bill should solicit community feedback at an annual public hearing or in a comment period for the OHS community benefit report this proposal has them doing annually. These provisions would ensure that community stakeholders cannot be left out of the process, ensuring greater hospital accountability and recognizes that community members are the experts on their community. Nonprofit hospitals have a responsibility to invest in the health of their communities due to their tax-exempt status, especially a responsibility to address health disparities and social determinants of health. However, Connecticut is currently unable to hold hospitals responsible for this deeper community investment. This legislation ensures that the hospital community benefit spending fulfills its actual purpose. We urge you to support this proposal and our recommended changes so we can hold our hospitals accountable to their communities. Thank you.
Thank you for your testimony. You've heard some concern on behalf of the hospitals about establishing a floor. Why is it so critical? Why is it that you believe that without a floor that the hospitals will not necessarily be fulfilling their minimal obligation, for lack of a better phrase?
I would say what we're really looking for here is a minimal obligation to that community investment portion of community benefit spending. And I think that having a floor for that type of spending is important because currently the percentage of community benefit dollars, at least from our examination of the Connecticut Hospital Association's numbers, is a pretty low percentage compared to some of the other financial community benefit that hospitals already provide. That isn't to say that hospitals are not doing what they need to be doing, simply that we want to see an increasement in that community building and that community investment. And we think a floor is one way to get there.
Thank you for that. Obviously, we have a lot to consider, and we'll try to chart a path that honors our desire for both transparency and having every hospital meet its obligation. I don't see any further questions, so thank you for your testimony today.
Thank you.
Next up is number 21, Christian Eason, followed by Eleni Diaco Giorgio.
Thank you. Distinguished members of the Public Health Committee, my name is Christiane Eason, and I am the Vice President of Sports Safety at the Corey Stringer Institute. I am submitting this testimony on behalf of the Corey Stringer Institute and our full support of House Bill 6492. One of our goals at KSI is to reduce catastrophic injuries related to the top causes of death in sport. Each year, exertional heat illnesses account for approximately 16% of all sport-related fatalities in high school and college athletes. While it is not possible to eliminate all catastrophic injuries and illnesses related to sport participation, there are numerous strategies that can be taken to mitigate the risk. The Interassociation Task Force for Preventing Sudden Death in Secondary School Athletic Programs describes the importance of educating coaches on the common causes of exertional heat stroke and predisposing factors in preventing exertional heat stroke fatalities. Additionally, the document lists the lack of education and awareness of exertional heat illnesses among coaches as an extrinsic contributing factor to exertional heat stroke. Coaches play an important role in helping prevent exertional heat illnesses because they can structure their practices and workouts in ways that can reduce risk. It's also important that coaches are educated on the typical signs and symptoms associated with exertional heat stroke so they could recognize when an athlete is in distress and activate their emergency action plan to help ensure the athlete receives appropriate care. In Connecticut, coaches are required to complete education on sudden cardiac arrest and concussion annually. However, no requirements are currently in place for the education of exertional heat illness. Adopting this bill would help mitigate the risk of catastrophic illness and injuries by ensuring all interscholastic and intramural coaches in the state of Connecticut complete an exertional heat illness education program. Education is a crucial component of preventing exertional heat illnesses. At KSI, we always advocate for the presence of a healthcare provider, such as an athletic trainer on site at practices and games. Whether that's possible or not, it's important for coaches to have this education to help prevent exertional heat illnesses and protect the health and safety of student athletes. The more eyes that are looking out for the well-being of these young athletes, the better. Thank you for allowing me to provide this testimony today.
Thank you so much for your testimony. I was a high school administrator, and I was quite surprised to find out that this wasn't included, at least for the state in terms of the training that coaches are given. So I thank Representative Claire DeStitria for bringing this to our attention. Representative Claire DeStitria, go right ahead.
Thank you, Madam Chair. Thank you, Christy, for testifying today. First question for you. Why is something like this bill on heat illness so important for our student athletes?
Well, I think, as I mentioned in my oral testimony, it's so important because coaches play a really vital role in structuring their practices. And if they're educated on the causes of exertional heat illnesses, they can set up their practices in a way that can help reduce the risk. Additionally, it's always important for coaches to be aware of potential signs and symptoms so that an athlete presents as distress, they can activate their emergency action plans. And we know that with the appropriate treatment, exertional heat stroke is 100% survivable. So the more people that are looking out for the well-being of our student athletes, the better.
Thank you. And we know that we have emergency action plans in children's now, so hopefully we'll get these two important pieces of legislation passed this year. But do you think, why do we need this in the Northeast? We're in the North. It's not like we're in Texas or we're Alabama where it's really, really hot. So do we have an issue up here in the Northeast?
That's a great question. So what we know is that the body acclimates to the environment in which it participates, right? And so individuals who are practicing in Texas or in Georgia, their body acclimates to that environment. But here in Connecticut, our bodies acclimate to this environment. We also know that there are many predisposing factors to exertional heat stroke. So a lot of equipment, if you're out at a football practice and you have shoulder pads on and you have helmets, that can increase your risk. And I'll also point out that, at the Corey Stringer Institute, we work with the NCCSIR, which is the National Catastrophic Institute that reports on sports-related catastrophic injuries. And we see these events happening in the Northeast. Some of you might be aware of the case in Maryland where Jordan McNair died of exertional heat stroke. They have a very similar climate to Connecticut. So yes, heat illnesses are definitely a concern in Connecticut, just like they are in Texas or Florida or California.
And my final question is is death from heat illness preventable?
It's 100% preventable. If you can recognize an exertional heat stroke, activate the emergency action plan and get athletes appropriate care by cooling them down efficiently, getting them in a cold water immersion tub as soon as possible, it's 100% survivable. And we have lots of data from the Falmouth Road Race and other data points to show that.
Thank you. And that's our goal with heat illness education and the EAP, the Emergency Action Plan. We're saving lives. And we're preventing death and enabling our student athletes, if something does happen, for them to get back to the sport they love as soon as they can in a safe and possible manner. But thank you so much for your testimony today. Thank you, Madam Chair.
Thank you, Representative. And like I said before, thank you so much for bringing this to our attention. I think it will save lives, and that's always such a good place to be when we're doing this work. So thank you for that. And thank you for your testimony today. I don't see any other questions. Have a great day. Next is Eleni, and I don't know that I could attempt to pronounce your last name. Would you please tell me your last name?
Sure, it's Diaco Georgiou.
Oh, it's not, okay, Diaco Georgiou.
You just got to split it up, and it's not that hard. Yeah. It's very intimidating when you first look at it with all those vowels, but you just...
It did intimidate me, I have to admit. So please go ahead.
Chairman Abrams and Steinberg and honorable members of the Public Health Committee, I would like to use this opportunity to offer this testimony on behalf of the Connecticut Athletic Trainers Association, where I serve as the co-chair for the Governmental Affairs Committee. This testimony is in favor of House Bill 6492, an act concerning exertional heat illness education for certain coaches. This bill proposes that those who hold a coaching permit and are coaches of intramural or interscholastic athletics complete an exertional heat illness awareness education program. This education awareness program will include the recognition of signs and symptoms, proper medical treatment, and the dangers associated with continued participation of someone with suspected heat illness. In the beginning of this bill, exertional heat illnesses are defined and include heat cramps, heat exhaustion, heat stroke, and heat syncope. Heat stroke is a medical emergency and is life-threatening. Heat illness education for coaches is important because exertional heat illnesses are 100% survivable if recognized immediately and treated appropriately. When proper timely treatment is rendered in heat illness, a life will be saved. This bill would also require education training on the prevention of exertional heat illness through acclimatization, the progression of exercise tolerance in the heat, and safe versus unsafe conditions. A 55% reduction in exertional heat illness is observed in states that require a heat acclimatization period prior to full athletic competition. Proper practice and contest modifications secondary to wet bulb globe temperature readings is a crucial preventative step that needs to be taken to drastically reduce the incidence of exertional heat stroke, one of the top 3 causes of death in athletics. The main focus of the educational modules for coaches is on prevention and recognition of heat illness to lessen the likelihood of one of these illnesses occurring during practice or competition. The requirement of education regarding exertional heat illness is vital in the care of our students. I appreciate the opportunity to provide testimony in support of House Bill 6492. Thank you for your time.
Thank you so much for your testimony. I have a question for you. Are some town school systems doing this already? Is this just to make it more uniform, or is it not happening anywhere?
No, there have been steps taken. No, the CIAC has taken steps towards, making sure that there's practice modifications and that coaches understand those practice modifications. Acclimatization, or, that period during preseason usually where we allow just the body to get used to participation. Definitely something that our high schools have been doing, and something that we would like to continue to see, because as Christy from the Corey Stringer Institute also mentioned, we can prevent this from even starting to happen as long as, and if we could recognize it and see it right away, we kind of shut that kid down, we make some modifications, and then we just kind of continue with our normal day. We don't even have to get to the medical emergency part if we could do the whole prevention piece.
Right. Thank you so much, and thank you for the work you do. Representative Claire DeStitria.
Thank you, Madam Chair. Thank you, Eleni, for testifying today. I think you may have answered most of my questions, and Senator Doherty also asked it, but the basic question is heat death preventable?
Yes, so it is preventable, and by understanding the steps we can take to prevent them, especially in those hot climates, or when we have a lot of humidity, those August preseason days, it can occur at any time. So I don't want you to think it only occurs during that time. It can occur at any time, anywhere, really during any part of the year. But if we know to recognize any signs and symptoms and let the body get used to that heat or whatever conditions that they're going to be participating. I mean, this is a heat bill, but even if I was to participate in very cold weather, I need to allow my body to get used to that. If I was to go skiing in some high altitude, I would have to let my body get used to that type of climate. So it's really about allowing your body to get used to whatever climate it's going to be in, and that will lessen the risk of us dealing with some sort of medical emergency.
And what's been done in Connecticut for recognition and prevention of heat illness up to this point?
Sure. So I know the CIAC and the CATA worked really hard. The CIAC donated cold water immersion tubs to certain schools. The schools said if they needed one or not, and the CATA actually helped deliver those cold water immersion tubs. I know in the policies and procedures, I may be using the wrong term, but coaches are aware of, heat illnesses and, the cold water immersion tubs and, all of that stuff too. So steps have been taken in regard to educating coaches on heat illnesses, but also having the proper equipment on site if you do see one, especially with the cold water immersion tubs.
Okay, thank you so much for your testimony today. Thank you, Madam Chair.
Thank you, Representative. I don't see any other questions, so thank you so much, and thank you for your indulgence in my stumbling over your last name. So.
Oh, that's okay. It happens all the time. It's an icebreaker. It's totally fine.
Thank you. Next, we have number 23, Amanda Brenner. Amanda, go right ahead.
Senator Abrams, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Amanda Brenner. I am an MSW candidate at the UConn School of Social Work and the Public Policy Intern at the Connecticut State Office of the National Alliance on Mental Illness. I'm here today in support of HB 6557, an act concerning social and emotional learning. We can increase students' emotional intelligence through social emotional learning and provide them with the resilience that fortifies mental health, by teaching them early on about self-awareness, self-management, social awareness, responsible decision-making, and relationship skills. Ultimately, these students will become our next generation of leaders with both respect for the law, the drive to challenge injustice.
Ms. Brenner, can I interrupt you 1 second? You said you wanted to testify on 6557?
Yeah.
I believe that's an education bill.
Okay.
And this is the Public Health Committee?
Right. Sorry.
So I think you got into the wrong group somehow.
Okay, thank you.
So we'll try to see if somebody can help you get into the right. The Education Committee is holding a public hearing today. And,
Okay.
they are hearing this bill, I believe. So we'll
Okay,
try to
thank
get you
you.
over there. Thank you. Next, we have Win Edwards. Go right
Senator
ahead,
Abrams,
sir.
can you hear me?
Yes, go right ahead.
Senator Abrams, Representative Steinberg, Senator Wong, Senator Summers, Representative Pettit, and other esteemed members of the Public Health Committee. My name is Win Everts, and I live in Norwalk with my wife and 30-year-old son with IDD, and I'm the Executive Director of the ARC Connecticut. You have my written testimony, and I apologize, there are some typos in it. But we are, in general, supportive of Senate Bill 328 and 329. And despite the text of the bill being sort of general, as compared to some of the issues inside the IDD community, I'll explain to you why we support these bills. With respect to both bills, the ARC wholeheartedly supports developing a strategic plan to ease or lower the waiting time for individualized services, meeting the needs of each individual with IDD that's eligible for those services. We think that this plan should include providing plain language training and information to families well before their loved one with IDD transitions into DDS services. That information should concern the full array of supports available, person-centered planning resources, and the individual's rights within the system. Secondly, service and support descriptions should be modified to satisfactorily support individuals with IDD and complex medical and/or behavioral needs in the community by developing access to the resources that those individuals need to be successful. And then finally, strategies should be developed to enable individuals with IDD to receive services and supports when and where they need them according to their individual plans. All of these three things have to do with the rigidity of our present system. And these should be able to be overcome. And if anything, some of the things that's happened during the pandemic will enable that to happen. The second aspect of Senate Bills 328 and 329 concerns mandating OPM to consult stakeholders on any plan to close one or more facilities operated by DDS. Based on the assumption that a plan referred to in this particular section of the legislation is not finalized and would benefit from stakeholder engagement, we support this because we basically think that consultative stakeholder engagement that includes discussion of the potential support alternatives available to people that are impacted by the closure and employment opportunities that for the workers that are impacted by the closure makes sense to go forward so that any kind of closure is a smoother process. We also think that there should be a very clear timeline for implementing the plan and then a very inclusive dialogue about the future reuse or repurposing of the closed facilities. The third aspect of Senate Bill 328 and 329 concerns providing notice of when eligibility for state-assisted services will end. I'm not sure exactly what state-assisted services mean, but if one is receiving services from a state-financed entity like a public group home or one of the ICFs or something like that, I think that notice is really important because you need to make plans.
Your
And
3
that's
minute
really,
mark. You hit your 3 minute mark if you wouldn't mind concluding your remarks.
Yep, okay. And so those are the reasons for it. And I'd like to thank you all for trying to improve the lives of all the people who live in Connecticut. I'm happy to answer any questions.
Thank you so much for your testimony, and thank you also for your work in improving the lives of people in Connecticut. It's appreciated. I don't see any questions at this time. You said you submitted written testimony, correct?
Yeah, except there's a sentence that's not finished, but it's really not material.
We don't correct your grammar or spelling. We just look at the ideas. So thank you very much. Have a great day. Next we have Kirsten Eek.
Hi there.
Go right ahead.
Hi there. My name is Kirsten Eck, but I often
thank
speak
you.
up. Dear Senator Abrams, Representative Steinberg, and members of the Public Health Committee, my name is Kirsten Eck. I live in Avon, Connecticut, and I'm a physician. I stand in support of HB 6550, an act concerning the Office of Health Strategies recommendation regarding various revisions to community benefits programs administered by hospitals. Tying community benefits programs to needs which are identified in community health needs assessments is a critical component of hospitals serving as anchor institutions in their communities and can help us advance health equity by addressing the barriers to health that in many cases keep patients coming back over and over for hospital dollars spent on treating them, when these things could be addressed more effectively at the community organization level and keep people healthier. And that will also free up spaces in our hospitals where we can more effectively treat people who are hospitalized. The pandemic has highlighted how important community resources are to maintaining health in times of vulnerability. Community benefit dollars can address disparities and social determinants of health that contribute to them. Supporting a community benefit and a community building spending floor that ensures that hospitals' reinvestments stay local and help financially supported community resources. In my opinion, community organizations that serve our hospitals are fundamentally important to treating the upstream health problems and keeping people healthy. I feel that reporting should include information about health outcomes, detailed data describing the demographic makeup of the community that the hospital serves, and should include how the hospital identifies and prioritizes community needs, including soliciting meaningful community input and feedback. I know this is difficult for hospitals that serve a large catchment area, but I do think it's critical that we identify who comes to us for care and support them back with community organizations based on needs. Thank you for the opportunity to testify and act concerning this, the Office of Health Strategies recommendations.
Thank you very much. We have a question for you, Representative Foster.
Yes, hi.
Hey, Doctor, thank you so much for joining us today. So as you were speaking about this, it brought to mind that I'm familiar that the Connecticut Hospital Association has endeavored to partner with the Unite Us platform. Are you affiliated with the hospital? I don't think I heard that in your.
I am, but I'm speaking on my own.
Okay.
Yeah.
Well,
yeah.
So has the organization you partnered with been part of the pilot launch of the Unite Us platform? And is that something that we should be considering as part of this legislation, at least conceptually, that it's part of their efforts and endeavors?
I'm not sure. I'll have to learn a little bit more about that. I know the organization which I serve has a strong population health group working to identify these needs and reach out to people who are found to have extra needs and pull them back in. So, but as far as the one specifically you're talking about, I would assume so. I would have to learn a little more though.
Yeah, the system was started out of the VA, and it was meant to create a warm baton pass between hospital providers and the community organizations that also serve them, where it's not just a handed a slip, here's your referral that you should go to, but it would allow for data collection to understand the interplay between hospitals and the community associations they might be doing referrals to. So as I was reading this bill in preparation, I was curious if we were going to hear people saying we're already working towards this with that platform or something along those lines. So,
no, that's an excellent point you raised. Yeah.
Thank you.
Thank you.
Are you all set, Representative? Okay. Well, thank you so much for your testimony today. I don't see any other questions, so thanks for being here and have a great day. Next, we have number 26. Brenda Morsetti. Brenda, go right ahead. You're on mute right now.
Good morning. I'm speaking in support of House Bill 5575. And dear co-chairs, senators, and representatives, I am Brenda Morsetti, Vice President of Naugatuck Valley Project former 1199 Executive Board member and retiree of Waterbury Hospital after 33 years of employment. The quotes I will be reading to you today are from a confidential meeting of MVP, Naugatuck Valley Project, and Waterbury Hospital / Prospect Medical employees with their consent. Number one, I have never experienced the level of danger that I have experienced in the past couple of months. The difference between the first wave and this wave is that they had shut down elective surgeries and just concentrated on the pandemic. This time, they are continuing to do open hearts. They are continuing to do elective surgeries, and that has added such a burden on the nursing staff. We don't have the nursing staff for that. If you are telling us we're in a pandemic and you are mandating us, then I think you need to batten down the hatches and concentrate on the pandemic. I know surgery makes them money, but I am their breadwinner. The nursing staff and PCA staff, we are what's keeping that place open, and they are burning us at both ends of the candle. Quote number two, I am not caring for my patients any longer. I'm holding on by my fingernails. I'm hoping they stay alive. Quote number three, this is dangerous. This is scary. These people are going to die. Quote number four, there is something terribly wrong happening in that hospital. Don't be a patient there. Don't be the fifth patient in tele. Don't be the sixth patient on a med-surg floor or the fourth patient in ICU. Quote number five, hospital sent an email asking staff to refrain from telling patients that they are short-staffed so that the patients don't suspect that they are aren't getting good care. Quote number six, I don't think the layperson understands what a patient ratio is or should be. Quote number seven, they shut down visiting months ago, so now we don't have any witnesses. Quote number eight, I put in a request for medication at 8:30 a.m. I called at 2 p.m. and it still wasn't ready. I just left at 7:30 p.m. and it still wasn't up. Quote number nine, there is no such thing anymore at Waterbury Hospital as a staff medication. It doesn't exist. You can't get it, and that's bad. And when I don't have a cardiac med and I need it, then that's a problem. This is what dedicated workers at Waterbury Hospital, Prospect Medical are dealing with.
Sorry, you hit your 3-minute mark. If you wouldn't mind concluding your remarks.
I urge you to support House Bill 5575. Thank you.
Thank you very much for your testimony. I have to be honest that I'm not sure how your testimony connects to that bill. If you could help me understand that a little bit.
We the community, need the for-profit hospitals to be more, they're very opaque at this moment. They need to be held to at the same standards as nonprofit hospitals.
Okay, yep, that's what.
Thank you.
The other thing I'm wondering, what is the Naugatuck Valley Project? Can you tell me what that is?
The Naugatuck Valley Project is an organization of community leaders and unions, a coalition of community leaders and unions that work towards the betterment of the Naugatuck Valley.
Thank you. Appreciate that.
You're welcome.
I don't see any other questions at this time. So thank you so much for being here and for your testimony. Appreciate
You're welcome.
it. Next, we have number 27, Ed Hawthorne.
Thank you.
Welcome. Go right ahead.
All right. So good morning, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Ed Hawthorne. I reside in Wolcott. I'm proud to represent the working men and women of Connecticut as the president of the AFL-CIO's Western Connecticut Area Labor Federation. I'm here today to testify in favor of proposed House Bills 5575 and 5991. I support these bills because I've had the unfortunate experience of witnessing Waterbury Hospital, where 4 generations of my family were born, transform from a safe community-based hospital, the one that cuts every corner in the name of its shareholders, since the for-profit entity Prospect Medical Holdings Incorporated took ownership. When we enter a hospital, we all expect the best care possible. It is safe to assume that no one enters a hospital and requests the best care on a budget in order to please stockholders. Brenda Morissette summarized the quotes that I was involved in that meeting. The Western Connecticut ALF was involved in that meeting as well. So I won't go over those quotes again, but I will share with you that we had another similar meeting that was confidential on March 30th, 2020 with the workers of Waterbury Hospital. Approximately 40 nurses and technicians who were employed at Waterbury Hospital attended. And one employee, just to go over how this hospital treats its employees and the for-profit model and how it affects the workers. One employee shared that they were not permitted to change out their N95 respirator for a week or until it was visibly soiled. Numerous other workers were concerned about the money-saving decision to place some workers on furlough and then have a maximum patient-staff ratio. The most eye-opening example, I think, of this negligent behavior of the hospital was furloughing medically trained workers and having the security personnel take the temperatures of the workers and also ask the COVID-related questions as staff were entering the building. Prospect Medical's business model places its shareholders' interest before that of the community health. This is supported by the statistic that 3 out of the 4 of the lowest rated hospitals by the Centers for Medicare and Medicaid Services for readmissions for hospital-acquired conditions are Manchester, Rockville, and Waterbury Hospital, all owned by Prospect. HB 5575 would establish standards of health and hospital care for private hospital ownership in Connecticut as a means for prioritizing best practice for patient care over shareholder dividends, whereas 5991 would require for-profit hospitals such as these hospitals that I've named to be held accountable to the same standards of public disclosure as nonprofits. Only when we are able to get that knowledge and hold these hospitals accountable will these conditions change. I thank you for your time. I thank you for everything that you do for your constituents and the community's health. And I urge you to support House Bill 5575 and 5991.
Thank you very much. Thanks, Mr. Hawthorne. I don't see any questions at this time, so thank you for your testimony. Have a great day.
Stay safe.
So, next is David Hannon. Mr. Hannon, go right ahead.
Thank you. Good morning, good morning, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is Dave Hannon. I'm currently the Secretary Treasurer of CHCA District 1199 of the National Union of Hospital and Healthcare Employees. I'm testifying today in favor of proposed House Bills 5575 and 5991. As an elected officer of the union that represents both the registered nurses and technical employees at Waterbury Hospital, I support these bills as an effort to address accountability of Prospect Medical Holdings, the for-profit out-of-state owner of Waterbury Hospital. Despite supporting the acquisition of Waterbury Hospital by PMH, my union had serious concerns about the company even then, concerns that have only multiplied since the pandemic. From problems early last year with respirator availability and distribution, through a layoff of union members and their transfer to lower paying non-union jobs, and the offshoring of some of these jobs to call centers in other countries, to supply and staffing problems in nursing units, one thing is clear: profit above all else is this company's priority. I believe strongly that every healthcare provider must have other priorities: good patient care outcomes, patient and worker safety, the health of the community it serves. Adding to these concerns is the troubling record of Prospect Medical Holdings nationwide. Last year, ProPublica, a respected investigative journalism nonprofit, published a report detailing how PMH extracted $400 million from its hospital chain by loading these facilities with debt while starving them of supplies, repairs, upgrades, and staffing. I was struck by the similarities between what I read and what my members have been telling me about conditions at Waterbury Hospital. While I admit the situation in Waterbury is not yet as dire as what was reported in California or Pennsylvania or Rhode Island, it is of the utmost importance that we mandate community health standards and transparency now before it is. The two bills before this committee would be a good start in ensuring that PMH and any future for-profit hospital system maintain community health standards and be held to the same transparency rules that nonprofit hospital systems in the state are. HB 5575 would prioritize best practices for patient care over profit and shareholder dividends by establishing community standards of hospital care for private for-profit hospitals. HB 5991 will require that for-profit hospitals be held to the same standards of public disclosure as nonprofit hospitals by mandating they abide by statutes developed by the legislature that require nonprofit hospitals to disclose the names of its top earners' salaries and benefits, the members of its board of directors, its charity care expenditures, and other things in order to protect patients and their families. I urge this committee to support HB 5575 and HB 5991. We should not have two separate standards for hospital systems operating in the state. Thank you for your time.
Thank you very much, Mr. Hannon. Thanks for your time testifying today. I don't see any questions, so thank you very much and have a great day.
You too.
Next, we have number 30, Glenn Lugarini.
Yes, good morning, Senator Abrams, Representative Steinberg, Senator Wong, Senator Summers, Representative Pettit, and all distinguished members of the Public Health Committee. My name is Glenn Lungarini. I am the Executive Director of the Connecticut Association of Schools and the Connecticut Interscholastic Athletic Conference. CASI-IAC represents approximately 1,000 public and parochial elementary, middle, and high schools in Connecticut. We support a wide range of activities, both academic and athletic. CASI-IAC advocates for the best interest of schools, students, faculty, and administrators in providing exceptional education-based experiences. I am submitting testimony in support of HB 6492. Interscholastic athletics is the most widely participated in high school extracurricular activity with more than 70,000 student athletes engaged on an annual basis. HB 6492 seeks to enhance protocols that may contribute to a more efficient and effective response in heat illness through education and emergency response. CASI-IAC shares the focus of HB 6492 and has taken proactive steps to implement the foundations of this act. As a partner in the Connecticut Education Program, CIAC has proactively worked with the Connecticut Association of Athletic Directors and Connecticut High School Coaches Association to implement exertional heat illness education for those seeking a 5-year coaching permit. The information in that course is adopted from the Corey Stringer Institute. Additionally, this past year, CIAC partnered with the Connecticut Athletic Trainers Association, the Corey Stringer Institute, the Connecticut Association of Athletic Directors, and the Connecticut State Medical Society Sports Medicine Committee to develop an interscholastic athletics medical handbook. In that handbook, best practices in managing heat illness are identified and model templates for implementing those practices are provided. Recognizing the current financial strain on Connecticut school districts, CIAC recently surveyed its membership and purchased cold water immersion tubs for any member high school whose athletic program was in need of such equipment. The Connecticut Athletic Trainers Association supported this effort by delivering the tubs to each school for which a tub was purchased. In summary, CIAC supports the purpose of HB 6492 to provide the safest environment possible for Connecticut's interscholastic student athletes through heat illness education and protocols. Thank you for the opportunity to testify this morning.
Thank you, Mr. Lungarini. Representative Claire DeSpetria.
Thank you, Madam Chair. Thank you, Glenn, for testifying today. And I wanted to circle back on what you had said about the CIAC donating the cold water immersion tubs. How many did they donate?
I believe the final total was in the low 70s. I want to say around 70, 71.
And do you think, what percentage of schools do you think now have cold water immersion tubs?
At this point, 100% of our member schools have the tub. So we have 186 member schools. Any school that did not have that equipment was provided it this fall. We through the Athletic Trainers Association, we were able to deliver those.
Great, thank you. Thank you, Glenn, for your testimony. Thank you, Madam Chair.
Thank you very much, and thank you for that effort, Mr. Longarini. It's nice to know that everyone has that equipment now, because it will certainly save lives. So thank you for doing that.
Thank you, Senator.
I don't see any other questions, so thank you for your time. Have a great day.
Thank you.
Next, we have number 31, Eileen O'Grady.
Hi.
Right ahead.
Morning. Co-chairs and members of the Public Health Committee, thanks so much for the opportunity to speak in support of House Bills 5575 and 5991. I work for the Private Equity Stakeholder Project. We're a nonprofit organization dedicated to understanding the impact of private equity investments on a number of industries. I'm a researcher on the impact of private equity investments in healthcare, and I believe House Bills 5575 and 5991 are critical to providing the transparency and oversight necessary to protect hospitals and maintain quality of care for patients. I want to share an example of why I believe this bill is so important. Safety Net hospital chain Prospect Medical Holdings operates 17 hospitals in 5 states, including 3 in Connecticut. It's Waterbury Hospital, Manchester Memorial Hospital, and Rockville General Hospital. Prospect is owned by Los Angeles-based private equity firm Leonard Green and Partners. Since it took over Prospect, Leonard Green and the minority owners have collected $658 million in fees and dividends from the company, even as its hospitals have suffered operating challenges, underfunded pensions, and regulatory scrutiny. Leonard Green's 10-year ownership of Prospect has been rife with problems. Many of its hospitals have some of the lowest quality ratings. In 2019, state regulators placed Waterbury Hospital under review for deteriorating conditions that place patients in quote unquote immediate jeopardy. Prospect has been sued in California for allegations that its hospitals needlessly admitted homeless patients and elderly patients with dementia to boost Medicaid and Medicare payments. At the end of 2019, it shut down all of its facilities in Texas and sold its San Antonio hospital building to a luxury hotel developer. But despite these operational difficulties, Prospect's owners were lining their pockets. In 2018, Prospect was made to take on hundreds of millions of dollars of debt so that it could pay its ownership group a $457 million dividend. It then sold almost all of the real estate, including that of the Connecticut hospitals, to pay off that debt. The massive real estate sale left Prospect's hospitals with greater liabilities and fewer assets. Leonard Green essentially used the hospital company as a platform to raise debt and siphon out cash. This hasn't gone unnoticed. The mismanagement of Prospect continues to draw scrutiny from regulators, investors, lawmakers, and workers. It's made national news multiple times. Members of Congress, including Representative Rosa DeLauro and Representative Johanna Hayes, have sent letters to Leonard Green detailing the numerous problems with its ownership of Prospect and asking the firm to return the fees and dividends it collected. Leonard Green's looting of Prospect may not have happened if we'd had the tools to monitor these kinds of transactions and get in front of this kind of bad behavior. We can't allow Wall Street to raid the hospitals at the expense of the communities they serve. I urge you to support these bills to ensure that hospitals in Connecticut remain at the service of patients and not Wall Street investors. Thank you very much.
Thank you. Representative Steinberg.
Thank you, Madam Chair, and thank you for your testimony today. Honestly, I didn't know somebody with your kind of background existed analyzing the impact of private equity. And obviously, I know you would agree that this problem is broader than just acquisition of for-profit hospitals. We have seen a trend to acquisition of physician practices and a number of other ancillary services in a fashion that I would suggest many on the committee have become alarmed. Particularly as you described, it may be in conflict with aspects of quality and access that are very important to us. I don't know if you have anything to add, but what have other states done with regard not only to hospitals, but also in terms of practices and other aspects of delivered care to protect the consumer in this case?
What have other states done?
Yes.
Your question?
Yeah, I mean, best practices, so to speak.
I think these bills are a great place to start. I think transparency is a great place to start. One of the major problems with private equity ownership of healthcare is the opaqueness of the industry. It's very hard to know what these companies are doing with critical healthcare assets like hospitals, like physicians' practices like nursing homes. It's very hard to tell, for example, when dividends are taken out and paid to the private equity owners. That would not be the case if we had bills like this that basically allowed us to better monitor what's happening with the financials and make sure that money isn't being just extracted from them.
So you would support the idea of requiring such transparent documentation from all healthcare groups owned by private equity?
Yeah, I think transparency is a great place to start. And certainly if it could be extended to nursing homes and any other kind of healthcare company, that would be the ideal. I think it is crucial that this happens on the state level because I think that's really where a lot of this kind of oversight can start.
Thank you very much for your testimony. Thank you, Madam Chair.
Thank you, Representative. I don't see any other questions, Ms. O'Grady, so thank you for your testimony.
Thank you.
Next, we are going back to 29, Maribel Rodriguez.
Good morning, co-chairs, senators, and representatives. My name is Maribel Rodriguez. I am a resident of Waterbury and an organizer of SEIU District 1199 Northeast. I am going to read to you the exact words of 1199 members working at Waterbury Hospital that they made during a confidential meeting of Naugatuck Valley project members and Waterbury Hospital Medical Holdings workers recently. The weekend before this is the first quote, "We didn't have incontinence pads for Friday, Saturday, Sunday, Monday for incontinence. We were flipping them over. We were using sheets. We were using towels to go in between people's legs. Number two, you have infections and we are going to have people sit in urine because you don't have supplies." Quote number three, "I can't tell you how many times I've had to use my gown for a COVID patient, a MRSA patient, and a C. diff patient. I shouldn't have to choose which disease to use my gown for. I had to save one gown to go into a COVID room, and I had to go into a MRSA and C. diff room with no gown. Too many ICU nurses got sick at work. Hospital directives switching back and forth between those who get sick using short-term disability and workman's comp. Unclear instructions from the hospital. Number five, we were given N95s to use for transport, but there was no definite time limit on use provided. Instead, we were supposed to use them until they fell apart, and then we could ask for a new one from the supervisor. If the mask broke after hours when the boss wasn't available to give a new mask, then there was no supervisor to get a replacement from, and we have to do without. Number six, the hospital initially established a 2-hour waiting period before entering a COVID positive room to clean it. In December, they decided without explanation that we could go into the room immediately after the patient left to clean it, if the room wasn't assigned to another patient right away. They previously said the wait period was to protect the worker, as COVID can stay airborne for a length of time. And workers are concerned about this sudden policy reversal, not considering the workers' safety. This is what dedicated 1199 union workers at Waterbury Hospital are experiencing. Please support Bill 5575. Thank you.
Thank you very much, Ms. Rodriguez, for your testimony. I don't see any questions at this time, so thank you for being here and have a great day.
Thank you. Same to you.
Next, we have number 33, John Brady. Go right ahead, John.
Good morning, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. My name is John Brady. I'm a registered nurse and the Executive Vice President of AFT Connecticut. Thank you for the opportunity to testify. I'd like to testify today in support of 3 bills, 6550, which is the act concerning the Office of Health Strategies recommendations, 5575, which is an act establishing community standards of health care for-profit hospitals, and 5991, an act concerning for-profit hospital transparency. Hospitals play a vital role. I have submitted written testimony. I'm going to try to summarize it for you. Hospitals play a vital role in the overall health of Connecticut's residents. The COVID pandemic has made that role even more clear. The role extends beyond the doors of the hospital into the communities which they serve. That is why, under the ACA, hospitals must perform community needs assessments. The goal is for hospitals to pull in all area stakeholders, from healthcare, social services, and community members, to determine the needs of that particular community and to develop and implement a plan to address them, thus raising the overall health of the community they serve. That goal is not always achieved, and the vital role that the hospitals are charged with is affected when it is not. These bills are a step in that direction of correcting this. 6550 and 5575 directly address the link that should exist between true community needs and a plan from the hospital that addresses those needs. 5991 would provide oversight of hospital financials, which is important in the overall ability of a hospital to carry out true community need plans. If I could just give you 2 examples of the disconnect that sometimes occurs between community needs assessments and hospital strategic plans. Currently, Hartford Healthcare is attempting to end the labor and delivery services at Wyndham Hospital. Community Coalition, to which we belong, believes that labor and delivery is a vital core service for the hospital and a vital need of the community. We are concerned that there is a disconnect between the community needs assessment and this discontinuation of a service that is vital to community need. In Rockville, we have another concern. Prospect Medical Holdings, which owns Rockville and Manchester Hospital, has shifted vital services from Rockville Hospital to Manchester Hospital under a temporary COVID-19 executive order. Our fear is that once the executive order is ended, Prospect will move to make these changes permanent and leave the community of Rockville without vital core services. In closing, I want to thank the committee for the opportunity to testify. I also want to thank you for the great work you do on behalf of the residents of the state of Connecticut.
Thank you very much, Mr. Brady. I don't see any questions at this time. Appreciate your testimony. Have a great day.
You too.
Next is number 35, Pastor Elizabeth Rosa. Pastor, you're on mute. There you go. Go right ahead.
Okay, good afternoon, Senator Abrams, Representative Steinberg, and members of the Public Health Committee. Am I being heard?
Yes, you are.
Okay. Okay, my name is Pastor Elizabeth Rosa. I co-pastor Iglesia Cristiana Casa del Perdón, which is House of Forgiveness Christian Church in Waterbury. My husband and I, Bishop Rosa, have been there for 42 years. Our congregation is very diverse. We have the elderly, we have the poor, we have people with insurance, others do not have insurance, others have Medicaid, Medicare. Our church is also a member of the Naugatuck Valley Project. And for the past 25 years or so, we have been working for justice in the community. And I'm here to express my concern about the quality of patient care at Waterbury Hospital. Since the purchase of, the new owners, Prospect Medical Holdings, in the late 2016, it has been operated as a for-profit hospital. And as we have heard with the previous comment, they also own Manchester Hospital and Rockville Hospital in our state. Prospect Medical Holdings, have 3 hospitals in the state, and they have shown in last readmissions in Connecticut that they are poor on that. it shows the worst 4 hospitals in Connecticut for patient readmission by the Centers for Medicare and Medicaid Services, CMS. The year before, private medical for-profit hospitals had some of the worst readmission rates in the state. That's very concerning to me as a pastor, but also it doesn't give my congregants, that confidence of, when you're trying to seek the best hospital care for our loved ones. Frankly, you would think that a hospital with a high number of Medicare and Medicaid patients, they would be vigilant in focusing on patient care areas that have been designated for particular attention from the CMS. We know that there are other areas of patient care and hospital operations that have been rated as insufficient at Waterbury Hospital over the last few years. And those incidents made the front page of our local newspaper when they happen. We know that the Joint Commission on Hospital Accreditation and the Connecticut Department of Public Health both gave Waterbury Hospital poor reviews after unannounced inspections in 2019. So we believe that it's time that the Connecticut legislature tighten up for-profit accountability by establishing community standards of health and hospital care for private for-profit hospitals ownership. I urge this body to support Bill number 5575. And I thank you for the opportunity that you give me to speak today.
Thank you very much, Pastor Rosa. Thank you for being here. I don't see any questions at this time, so have a great day.
Thank you for having me. Be safe.
Next is number 36, Joseph Canzanella.
Thank you.
Go
Good
right
morning.
ahead.
Good morning.
Good morning.
My name is Joe Canzanella. I'm the Executive Director of the Connecticut High School Coaches Association, and it is my pleasure to provide testimony today in support of Exertional Heat Illness Training Bill, HB 6492. The CHSCA represents approximately 4,000 high school and middle school sport coaches throughout the state of Connecticut. We provide member services, scholarship recognitions that impact our student athletes and our coaches on and off the field. Education-based athletics is the reason for our existence. At this time, I'd really like to recognize Representative Clarice Ditria on her work with this bill and recognize her for the many hours she's put into putting together a bill that we all can support. The safety of our student athletes cannot be overstated. We've worked for many years to ensure safety during training, conditioning, and competition. This bill will add a safeguard for our athletes and their families. CHSCA, in collaboration with CIAC and CAD, has provided required ongoing training, practical training to safeguard the physical and social emotional state of our student athletes of the state of Connecticut. Our support of HB 6492 would add another layer to protecting our children. CHSCA believes that the empowerment of this legislation lies within the education of our coaches, parents, guardians, and students. This life-saving training will be developed by licensed trainers, sports medical doctors, recognized organizations that research best practices in managing heat illness, and county medical associations that will become the standard of education for all responsible individuals of our student athletes. Once again, I'd like to thank Representative Clarice Ditria for all her work on this important component, and I urge the support of this bill of the Public Health Committee. Thank you for your time.
Thank you so much for your testimony today. I don't see any questions, so have a great day. Thanks for being here. Next, we have number 37, Priya Pawani.
Hello, everyone. I guess good afternoon. My name is Priya Fulani. My pronouns are she and her. I'm a pediatric endocrinologist at Connecticut Children's, and I'm the co-director at our Clinic for Variations in Sex Development. And I'm the director at our gender program as well, which provides care to transgender, non-binary, queer, agender, and gender diverse youth. I'm very thankful for the non-binary option on legal documents in Connecticut. I've already been signing these affidavits. It is going very well, thank you. But I do oppose this bill, largely again due to Section 7, which describes, and I'm quoting, a task force to study the circumstances in which surgery related to a person's intersex status is medically necessary. So regarding the listing of conditions, the medical classification of DSD in any of the consensus articles, actually DSD replaced the term intersex. At one point that was a negative term. And that classification includes anatomical atypia. So it includes CH. And as you guys have heard from patients and families with CH, they don't consider themselves intersex. So medical definitions may vary over time. Community definitions may vary over time. So that list of conditions, very complicated. And then there's that term, medically necessary. So are we using, for example, the insurance company definition? So last week, I tried to argue for an urgent prior authorization for a medicine to pause puberty for one of my transgender kids. And the insurance company said, medically necessary is only if immediately life-threatening, and they denied my request. But it's medically necessary for my teen to live their authentic life. So even if it went broader than that, okay, fine, PREA, it's not life or death. What about cancer risk? What's medically necessary there? So one of our intersex conditions is partial androgen insensitivity syndrome. 15 to 30% have a risk of testicular cancer here. And when you give that information as a provider to families, they may choose to observe. 30% might be high for another family. They may choose to discuss with you what would happen if we remove those gonads. So our job as providers is to educate these families, give them all the pros and cons of every approach. And then ultimately in this country, we rely on paternal autonomy. Parents, legal guardians make decisions on circumcision, cleft repair, cochlear implants, chemo versus hospice for their kids. Parents make these complicated decisions all the time, and we provide them the information to do that. And we need to provide the correct information, I agree. But trying to legislate that right, that's where I disagree. So I just overall don't agree that legislative regulation, this ask to list these circumstances and state when they're medically necessary, is a reasonable ask. I think there are many better ways to support these communities. I have listed them in my written testimony. And I'm happy to talk about that, but in the interest of time, I will end here and open it to questions. Thank you.
Thank you so much, Dr. Pawani. Appreciate your input. I do have a question for you, and that is, what is the objection to having a task force that would look at all the things that you talked about and how complicated it is, and to start open dialogue? That's how I was looking at it more, to start that dialogue, to look at best practices, to look at, what's happening in our state so that we can have a better understanding and then people can get the best care possible.
That's exactly what I proposed in my written testimony. So the way this is written is a task force that lists conditions where medical surgery is necessary. What I think would be a better use of everybody's time and more effective and more supportive is a working group. And mind you, the task force didn't say what the qualifications of these members are. They just say one person appointed by so-and-so, another person appointed by so-and-so. So I think we need to define that. It needs to be Connecticut residents. It needs to include adults with intersex conditions. It needs to include parents whose kids have intersex conditions by medical definitions. It needs to include a pediatric endocrinologist, a urologist, an ethicist, a general pediatrician. And our purpose needs to be redefined. This listing of conditions and listing medical necessity, instead of all that, it should be our mission is to come up with a path with strategies to improve the lives and healthcare for patients with these conditions.
Yeah. Thank you. Thank you for your answer. Appreciate it. Representative Pettit.
Thank you, Madam Chair. Thank you, Dr. Fulwani, for your forceful testimony and your
a care for many people with very complex psychological and hormonal issues. I do have some concerns about the appointment of the task force or committee, and typically for the time that I've been up here, they're appointed by a variety of people, the president, the Senate, the Speaker of the House, etc. And in this specific instance, it says within 30 days. There's not a lot of people in the state that are incredibly facile in this area, so it's a very limited population. So I think it might be tough to get it done within 30 days, and it almost, this I guess is more of a comment, almost would be better to get 2 or 3 of the leaders in the state to try to convene a group and then perhaps come back to the Public Health Committee for approval. But I'll move on to a question, having made that statement. If Section 7 is adjusted or removed, do you see a need for the remainder of this bill? Do you think there's some positive things for the patients you care for in this bill, or do you think there are also other issues that need to be attended to?
No, I think if Section 7 were removed, thinking about some of the other elements, I think actually the Judicial Committee pointed out there's Section 5G, I think it's repetitive. So we've already got the non-binary and X, which I'm very supportive of. So I'm not sure what else this bill would achieve other than what we've already started to do. So that legal documentation option is happening, and I'm fully supportive of it. If there are other areas where we need to allow our institutions some time to adapt that on everything, I'd be in support of that. There's nothing more specific that this bill is putting forth other than the task force and continued openness to non-binary options on documentation. So I'm fine with it. I'm just not sure if it's achieving anything new. Maybe it's just stating or reinforcing the same, which is fine.
Given the fact that you're one of the few sort of in the inner circle of people around the state working in this field, what do you think would be the most effective way to convene a task force or working group to consider many issues surrounding these conditions?
Yeah, I think this has been going on since the past. This is my 3rd year testifying again to this task force issue. And meanwhile, between Yale and Connecticut Children's, we already have started meeting to, what's the best way to provide care. They've already had a conference. The piece that I think we need to be better at is we need to pull more people from the community into these conferences. So we're already talking about what is the best ethical care. Are we really giving patients information without bias? Are we talking about the option of observation with the same depth and heaviness that we're talking about surgical or medical options? And I think we're doing better with that. There's more outreach for pediatrician information as well already happening. So that working group sort of with our teams, with the 2 multidisciplinary teams at CT Children and Yale, is already in progress. So that piece wouldn't be novel. I think we can do a better job of getting the other missing pieces into those working groups. I think that might be a start since that's already sort of underway. So it wouldn't be reinventing the wheel. I think that would be a good way a place to start. And I don't have a problem with expanding that. It's just that piece of legislative regulation that defines necessity and defines what is intersex when the communities themselves have varying opinions. I think those are problematic. But a committee to look further, starting with what we have and expanding it, I think that would be great.
Well, I thank you for that, and really thank you for taking the time out of a very busy schedule to be here. So take good care of yourself. Thank you.
Thanks.
Thank you, Madam Chair.
Thank you, Representative Pettit. I don't see any other questions. Dr. Fulani, thank you so much for being here with us today.
Thank you.
Next, we have number 39, Courtney Rowe. Ms. Rowe, go.
Hi.
Hi, go right ahead.
Success. Okay. Hi, Senator Abrams, Representative Steinberg, members of the Public Health Committee. Thank you for the opportunity to speak about Senate Bill 100. And I also have to just put in a thank you to your staff for organizing this hearing during the pandemic. It's clearly a labor of love. And finally, thank you also to the bill's sponsors for shedding light on the discrimination and misunderstanding suffered by the intersex community. I'm Dr. Courtney Rowe, a pediatric urologist at Connecticut Children's with Dr. Fulani. My pronouns are she and her, and I want to take a moment to update the Public Health Committee on the work the physicians of Connecticut have been doing to continue to improve our understanding and support of the intersex community since this bill was first introduced 2 years ago. First, we have continued our multidisciplinary clinics, which consist of pediatric urologists, pediatric endocrinologists, mental health clinicians, and others working in tandem to provide individualized evidence-based care for intersex children. I've seen some written testimony from 2 out-of-state adult urologists concerned about the objectivity of these clinics, and I would really encourage them or anyone else, including Public Health Committee members, to come visit a clinic and see how they work. Second, as Dr. Fulwani mentioned, these multidisciplinary clinics have combined into a working group consisting of invested physicians and ethicists from both Connecticut Children's and Yale University, focused on continually improving the medical care delivered to the intersex community of Connecticut. As you've noticed, we are moving a little slower than we had expected because of the pandemic, but the next step for this is to include advocates from the patient side, specifically here in Connecticut. Finally, the Yale University Program for Biomedical Ethics hosted a conference to hear voices on both sides of the discussion about surgeries in intersex people. This included people who are for surgery bans as well as people who are against them. And I think conversations like these are ultimately the most valuable things we can continue to do in the discussion about these complex issues. What has not changed is the opinion of the Connecticut physicians and the National Pediatric Specialists on Section 7 of this bill. For the past 2 years, the Connecticut AAP, the Connecticut Society of Urology, the American Urologic Association, the American Association of Clinical Urologists, the Society for Pediatric Urology, as well as, probably most importantly, the patient advocacy group CARES, have remained in opposition to the idea of creating a list of medically necessary surgeries. I really appreciate the many comments from community representatives that the goal of this task force is not to overreach into the relationship between families and doctors. And unfortunately, whether or not this was the intent, a list as currently described in Section 7 would prevent us from considering the full breadth of evidence-based treatment options. I don't think there is any physician who would ever offer a treatment that the state considered medically unnecessary. And I don't think that there is an insurance company that would be willing to pay for it. I am not saying that any family should be choosing surgeries. These are difficult and personal decisions, as we heard from the families who've had to make them. But if we are going to provide open-minded, individualized, evidence-based care, we can't walk into conversations saying a child can't have a surgery. Intersex patients and this community's diagnoses and experiences are too complicated to reduce into a list of medically necessary and medically unnecessary care. Ultimately, legislating one-size-fits-all medicine prevents the individualized, evidence-based care that is the center of best medical practice. I would respectfully request that the idea of a task force, as described in Section 7, be removed from this bill. Thank you.
Thank you very much for your testimony, Ms. Rowe. Appreciate it. I don't see any questions at this time, so thank you for being here.
Thank you.
Next, we have number 41, Olivia Rink. Go right ahead.
Thank you. Thank you. Thank you, members of the Public Health Committee. My name is Olivia Rinkus. I'm from Northampton. I'm calling today in reference to Bill HB.
I think we lost you. Can you try again?
Oh, yeah.
Ms. Rink? Thank you. Go right ahead. Try again.
Do you have me still?
I can hear you, but you're breaking up.
Oh, it might be the service. Okay, I'll try again. Okay, so I'm calling in reference to Bill HB 5991, an act concerning for-profit hospital transparency. I asked the committee to pass this bill. For-profit hospitals are housed on untaxed lands, meaning they're publicly funded and therefore their tax information should be public knowledge. In that respect, I also asked the committee to support HB 5575, an act establishing community standards of health and hospital care for private for-profit hospital ownership. Community knows what it needs from their healthcare providers, and healthcare is human right. Therefore, it is the right of the community to hold their providers to the people standards rather than the standards of for-profit business owners. And finally, I am calling, I'm also making a suggestion in reference to SB number 100, asking that the Section 7 be removed regarding the task force. Thank you for your time.
Thank you for your time and thank you for being here to testify. Appreciate it. I don't see any questions at this time, so have a nice day. We have someone else who came and now disappeared. Is Christopher Calasi here? I don't see him in the list. He was there a second ago. Christopher Calasi. He will be our last speaker, so I'm going to give him a moment, see if the administrators can get him back on. Okay, looks like we lost him. So I think that's it for today, actually. So a short day for us, but I think really good testimony and some good topics that we covered. So appreciate you all being here. We have a committee meeting on Friday. So we will see you all then, if not sooner. Anything else, Representative Steinberg?
No, Madam Chair, I know that today's hearing, this expeditious quality will kill our average for public hearings, but I'm very pleased that we were able to hear everybody today.
And it's nice that I know everybody's so busy, so have a great day, everyone, and thank you for your time today.
Thank you. See you next time.